What is it? What's on your time, Maynard?
Tigger, I think.
Yeah, good on. Yeah.
I'm disappointed Paul's not gone for a flowery shirt.
Yes, I could have jazzed it.
Good morning and croeso. Welcome to our board meeting. We have a packed agenda today, so we'll go straight into it. If I could just remind members that we've all read the papers and to keep questions and answers as succinct as you can so that we can do justice to the agenda. And I'd like to thank the executive and their teams for the clarity of the papers and the timeliness of their arrival. So thank you very much. So I'll go straight to the agenda. Do we have any apologies?
Chair, we have apologies from Winston Weir.
Thank you. Declarations of interest?
The usual whisk and procedure.
Thank you. Okay, thanks. And then the minutes of the public meeting held on the 26th of January 2023. Is everybody happy with the accuracy? Okay, thank you. So we'll approve those. And then the extraordinary public meeting on the 23rd of February, are they approved? Thank you. And then if we go to the matters arising, 2.3, are there any issues on the matters arising? Judith.
Yes, thank you, Chair. It's on the table of actions from the 23rd of February meeting. In the minutes, it notes the question about additional resources for the team who are responsible for the managed practices and primary care. And although the strategy is there in terms of forward planning, there isn't any reference to that. So I was just looking for an update on that action, please.
Thank you.
Yes, thank you, Chair. And we did subsequently discuss this in the executive team, and there are 3 posts that I think identified during the board meeting, which we're going to be progressing. One to support us on the sustainability and the management of the managed practices. We'll have 6, of course, from the 1st of April. A further one to help us think about the development of the strategy, and then one in terms of the team around sort of governance. So I think those 3 posts are in the process of being progressed. I will say and get the point in that at the time that we come to think about the wider primary care strategy, we'll be having further discussions with the exec team and board around the wide range of resources that we need. And that's about, you know, the corporate teams and how we work together really to achieve that objective. And we're already having conversations with Director of Planning and his team in terms of progressing that actually from next week's discussion with the multi-professional clinical forum. So looking forward to that.
Thank you.
Okay, thank you. Any other questions on tables of action?
Yeah, on the table of actions from the meeting of the 26th of January, PM 2313, the last bullet point under that section where we talk about triangulation of data. I don't think the patient experience report this for this meeting does have triangulated data or indeed trend data in it, and I was wondering what the position is with the development of that.
Yes, thank you for that. So it is still currently a bit of a manual process to make sure that we've got the full triangulation of all the intelligence and the data that we have available. So I have a meeting coming up with the performance team and also my own team to look at how we further strengthen the metrics and the measures that we've got within our safety dashboard, but also how we can try to enhance the opportunities for triangulation, so we can then reflect it in the board report. So I've asked the team to try and have a first hash of it, if you like, or a first go of it in the May report. But I think what we will find is a little bit like the patient experience report. The iterations of it will strengthen and improve as we go forward. So we're aiming for May to be our first attempt at providing some triangulation.
Thank you. Anything else on the action log? I've got a few points in relation to tying it down to some dates. So first of all, in the meeting held on the 26th of January, PM 22-205, it's going to be reported through Quality Committee. I wonder if we could agree a date. It will be post Q1.
I spoke to the Bev yesterday, the head of audit, to seek some clarification on when the audit outcome will be available. And he's working towards a June date for the report to be available. So I will work on that. I have said that I'd like it by the end of May to be able to get it into June Quality Committee, but I would rather it accurate than a rushed account. So I will keep the chair of our Quality Committee up to date.
Thank you.
Sorry, Chair, just to interrupt. If anybody's got a mobile phone near the microphone, can they just move it because it's just causing a bit of interruption? Thank you. Apologies.
Can we switch them off? Would that be easier, Jo?
Just if they're away from the mic, 'cause it's just causing some interference, Chair.
Okay.
Thank you.
Thank you. And then if we could go to PM 2316, the Cloyne-Hendy TB outbreak review. Again, when do we expect that to be completed and reported to the Quality Committee?
So we already have an action plan, Chair, and there's two parts of that. One is from the Public Health Wales team, where I've agreed with Public Health Wales that they will share with us their updates to their Quality and Safety Committee as they provide them. So we would bring those to the Quality and Safety Committee. We expect those to be 6 monthly from Public Health Wales. For us, our intention is to take the next update to Quality Safety in June. The Chair of Quality Safety is happy.
Thank you. And then, excuse anybody who doesn't know what the noise is. The windows are being opened electronically. Apparently they don't open in the rain. So we've overcome the West Walian weather, so we can breathe in this room. So thank you. And then PM 2325 about the presentation to the future People Committee, the Community Nursing Annual Report.
Yes, that's on the agenda for next week, Chair.
Okay, well, that's great. Thank you. Okay, thank you. We'll go now to the next item on the agenda, which is my report. I'll take the report as read, and I'll just go to a few issues. First of all, we were all very concerned to hear about the findings of the Auditor General in Betsy Cadwallader Health Board. And I'd like to take the opportunity to reassure the public and our staff that Audit Wales independently have found that this board is cohesive with good working relationships between executive and independent members, and we are stable and have a robust approach to learning and development. Obviously, there's always things that we can learn, so we will consider together as a board the learning from the issues which have arisen over many years, really, in Betsy Cadwallader. I'd also like to take this opportunity to sincerely apologise to members of the public and to staff for the difficult conditions that they have experienced in our A&E departments, highlighted recently in the Health Inspector at Wales report. I think it's fair to say that these conditions are mirrored across the UK and show the tremendous pressure from increased demand, from staffing shortages, and the difficulties in discharging patients, with almost a third of our beds being occupied by people who are medically well to be able to be discharged. That is not an excuse, it's a dreadful situation, and I want to thank all the staff, including my colleagues around this table, who are doing everything they can to make the situation better and to improve the conditions and to continue to care for people. I've also set out in my report the deaths in service, and I'm very sad to report the deaths of very respected colleagues, and wish to express on behalf of the board sincere condolences to their family, friends and colleagues. Alison Terry, who was a psychological wellbeing practitioner based in Glangwili and was an integral member of the team and worked with great integrity and compassion. And Reverend Roger Hart, who passed away in January and worked in our chaplaincy service for 22 years, supporting staff and patients in South Pembrokeshire Hospital. It's also, I've set out in my report, the success of our teams, which is absolutely wonderful to see, being recognised for their excellence nationally as well as locally. And that includes the nutrition and dietetics service, the green team, and our apprenticeship schemes. And for any of the members of the public who are listening at the moment, we are currently advertising for more apprentices. If you could pass that round in your communities. So on behalf of the board, a huge congratulations to our teams. It's also with real regret that we see the departure of Paul Newman, who's been a valued and dedicated independent member of the board since 2017. And as chair of our audit committee, he's significantly strengthened the assurance that we receive as a board. So thank you, Paul. And it's also timely to share that my term of office as chair will come to an end in October, which is later in this year. And both posts will be advertised shortly. And I encourage individuals who are interested in being part of this team, in delivering our strategy and in serving the people of Hywel Dda to apply. And finally, I'd like to take the opportunity to thank Mansell, who's the chair of the Community Health Council. It's the last day of the Community Health Council, which becomes tomorrow a new body, Citizens' Voice. And Mansell, I'd like to thank you for over many, many years challenging us and representing the people of West Wales so strongly. And I'm sure that you will continue being a great advocate. And I wish the new organisation, Donna, all the best with its new statutory powers and with the challenges that we all face together. So thank you. So that's my report. If anybody would like to ask any questions.
Chair, if I may.
Certainly.
It's not a question, it's really just to add to the comments that you've made around the Healthcare Inspectorate Wales report. And obviously we do receive unannounced inspections across a full range of our services, whether that's maternity, and obviously A&E is our most recent report for Glangwili Hospital. I think it's important that members of the public understand that we have many of the issues that were identified within that report were not a surprise. And I think I would be really concerned if we did have things identified to us that we as a board and as an organisation were not aware of. Importantly, for the public to understand, we do have a very detailed improvement action plan, not just for that particular accident and emergency department, but actually one that runs across the whole of the organisation, and that's led by Andrew Carruthers. And I think that the work that we're doing, certainly the patient walkarounds, the assurance visits, and we do our own internal unannounced attendance at various sites, including our accident emergency department, help us understand whether we're actually making the improvements that we have set out to make, or whether it's the work for us to undertake. On the back of the most recent report into A&E in Glangwili, we will also be holding a follow-up quality panel where both the medical director and I meet with the teams concerned to make sure that we're confident that the actions that have been set out have actually been taken in practice. So it's really to just give assurance that it's not a report that sits on the shelf.
Yes.
It's one that we actively engage with and follow through.
Yes, thank you, Mandy. Are there any other comments? Paul?
Just in relation to the new diabetes prevention programme, obviously good to see this. It's just to seek some assurance that this will also include targeting the learning disability population who are perhaps really prone or susceptible to this, and could I have some assurance about that?
Thank you, Chair. I can take that one. Yes, absolutely, Paul. I would expect any member of our registered patient population who's identified by their GP at potential risk of developing type 2 diabetes to be included within this, and to make sure that the right levels of communication and support were there to assist individuals and their families or carers. So I will take that back to the team and note that it's been raised, but I want to give you that assurance today. Thank you.
Delith.
Thank you, Chair. Just a positive, really. I've been privileged to be involved in a lot of the long service awards to our staff. And I have to say, I've been blown away by their commitment and their real love for Hywel and the population of the locality. I'd just like to have some assurance how we capture all that learning and all that experience formally, because it is a golden nugget that we can take to look forward to provide a service within Hywel. So I'd like to ask the board how we are going to do that.
That's a very good question.
Yeah, I'll try and take it, but I might look to Lisa a little bit as well, who's looking concerned at me right now. Probably about what I'm going to say. I mean, I think it is really difficult to try and capture that all in real time, and of course, across the health board, it feels different depending on where you are. You've just heard about A&E and understanding the pressures and the impacts that's having on staff. Of course, we do. I think we're the only health board in Wales that regularly surveys all of our staff, 1,000 a month, with an aim to doing all of them over the year. That feeds into the board assurance framework, so that does give us at least a temperature check. And as that database is building up, it's allowing us to do a bit of more longitudinal analysis about how people are feeling over the long term rather than just snapshots. So we've got some of that. Some of the work we do around our sort of staff experience reports are also useful in that regard, and we've got the relationship managers out there who've been writing their sort of culture plans for individual teams. So I think there's a lot coming together. I think I might just look to Lisa to see whether there's a way in which we can maybe draw all the threads of that together into something which is a bit more sort of comprehensive for the board, maybe on an annual basis, so we can get a sense of that.
Yeah, thank you for that question, Delith. It is a really good question, and we have got the performance report that goes to the workforce, the people committee. So we do look at the service of our staff. What we're trying to do at the minute as well is to see how can we help people think about what their roles could become as they start to reach perhaps what would be a natural end to their career because of perhaps the how strenuous a job is. So actually there's an awful lot that we can get from our employees around coaching, supporting, mentoring, helping to think about shaping the future of the organisation. So that's a piece of work that the OD team are doing in terms of how can we help for the retire and return. And of course the pension rules are changing from the 1st of April and also October. That mean people wouldn't necessarily have to leave to access their pensions. It's then how do we help them step down so that we can use all of that knowledge and experience that people have to help us move forward for the future. So we'll think about how we write that in a report and take it to the people committee. That's okay.
Great. That's great.
It's a good challenge.
Yeah, thank you. And I think when we go out as independent members, we go out on visits to listen to staff. And as you say, it's so rich when we give the long service awards, and there's often colleagues there to celebrate together. And as you know, when we do other visits, we send the information centrally to the board secretary to be collated. I think from those visits, if we could capture some of the information and the intelligence, then we could feed that into the OD team as well, or into Lisa's team. Yeah, and I think that would help us.
Yes.
But it is heartwarming to go out and
It's absolutely
yeah,
a highlight of my career,
yeah,
I have to say.
yeah.
And having been witness to one individual who has served the NHS in this area for 52 years,
Yeah.
I was just blown away.
Yeah.
And to see all those old colleagues there as well. And I think it would really help our succession planning and our recruitment as well, because there are lessons to be learned about how we support our staff to stay so long for us as well.
Perhaps Alwena could link in as well about, we publicise it internally. Perhaps we should be publicising some of those wonderful stories if the media would accept it externally.
Let's try and do whatever we can within social media channels at least.
Yeah. Okay, thank you. Is the board happy to support the work and also to ratify the actions that I've undertaken? Thank you, Diolch. So we now go on to the report of the Chief Executive.
Sorry, before we start, just to apologise to members of the public, we have had a technical challenge this morning, so I think for about the first 20 minutes the public haven't been able to watch. It is recorded, so there is a new link on the website which we think is now fixed, so I just wanted to apologise to everybody for that, Chair.
Thank you, Jo. Steve.
Thank you. Yeah, I can be relatively brief today. I think the report is largely self-explanatory, but there are just a couple of things I wanted to highlight from my report. The first one was around the work we're doing on health and social care integration. We've had the discussion document from Welsh Government, the Further Faster Together paper. I think to assure the board, there are many things in that paper that we were already working on prior to that discussion paper being put together. And we've largely started in the areas where we've got the biggest challenges, but the plan is that the work that we're doing will roll out across Hywel Dda. So the board will be aware, I think, from previous discussions that the Chief Executive of Carmarthenshire Council and myself met following a walk around in Glangwili recently. We're now at the stage, as a result of that discussion and the desire to do something different together that emerged from it, that we've agreed a plan, a co-sponsored plan between the Chief Executive of the Council and myself, and that plan is now being worked through by our teams, in particular Rhiannon Matthews, our lead for the Transform Urgent Emergency Care work, and we'll bring that back to board regularly because this is quite a big challenge for us, and we'll also ensure through Wendy that that's linked back into the council as well. The intention of that really is to see how far we can go before next winter, learn the lessons from it, and help, I would hope, to support a national debate about then what the long-term solution will be. For Pembrokeshire, which is probably our next most challenged area, we have a workshop established with them, I think it's in April, with the senior officers and the chief exec in Pembrokeshire, really to look at firstly where we are in relation to the Home First initiative, which has had some real benefit in the Carmarthenshire area, and ensuring that we've got that comprehensively across Pembrokeshire, and then to move on to some of the other things that we are now working with Carmarthenshire on. So that work will start in April, and again, very good engagement and commitment from the local council there. And then our next plan will be to go to Ceredigion, and I'll be meeting the Chief Executive of Ceredigion shortly. Although Bronglais does have some challenges, and of course this is in the context of everything being very challenging at the moment. It is probably the least challenge, which is why we're doing it in that order at the moment, so that we've got the capacity. But we do need to ensure we've got some new things on the ground before next winter. So I'm happy to take any questions on that, but we will be certainly bringing back more detailed reports in due course. I've also highlighted in the report the public inquiry, just to confirm to the board that we have been confirmed now as a joint core participant in Module 3 with 6 other health organisations. And I'm also asking for formal approval around the Memorandum of Understanding for the South Wales Spinal Network and the continuation of the National Imaging Academy for Wales hosting agreement at Cyntath Morgannwg Health Board. And then finally, I just wanted to finish with two things. Firstly, just to acknowledge the passing of the CHC and the setting up of the Citizen Voice body Chlias. I need to get my mouth around that a bit more. It's still not familiar. But when I came to Wales, it was with real pleasure that I saw we had community health councils. We lost them in England a number of years ago. And my experience in the 8 years that I've been here, many of them with Mansell and Donna, it's been a really supportive relationship, critical at times, and that's right, holding our feet in the fire. But I am confident the work that you've done, the work that your dedicated volunteers have done, and indeed the officers, has put us in a better place as a health board, and you've been a contributory factor in where we've got to today. So it's sort of with a slightly heavy heart that I see the words CHC going from our sort of lexicon, but I am looking forward to working with you both in different guises, I hope, to continue to help us on the journey we're on. And then finally, I just want to say a few words about Paul as well. I'm not going to be embarrassing Paul, but you've been a steady rock for me in this health board over the years that you've been here. Wise counsel, insightful, can't get anything past you. And again, that has really contributed to where we've got as a health board. And I'm going to really miss you. I think the whole board will miss you, but I just wanted to thank you for what you've done to help us move forward.
Thank you.
Thank you, Steve. questions?
Sorry,
Sorry.
I've just got the 23 questions on screen.
The floor's yours, Paul.
This is nervous.
I did actually have one question, if I may.
Please.
In relation to the South Wales Spinal Network. In the second bullet point there, it talks about each region. It's on page 47, page 120 in the bundle. It talks about these hospitals may have spinal consultants and may offer an emergency service. What does may mean in this context for our population?
I think it means they will. I don't think you can operate the system without them. Might just need to look at that language. Nothing gets past you.
I think it just reflects that they're still working through a lot of the detail of how those pathways will work. I think the intention is that there will be spinal surgery provision in both of those providers, but there may be some nuances in the pathway in terms of acuity or complexity that may mean they differentiate between the two sites as well. So there's still a bit of detail been worked through, I think.
So probably the intention is.
I think that needs to be probably.
We can have a
We
shall.
can tweak that.
Yeah.
Yeah. Lawyers like mays and shalls to be.
Yeah. Whenever you say reasonable, you start to twitch.
Absolutely.
Yeah.
Mean anything.
Yeah.
Okay, thank you. Derek and Mandy. Judith.
Thank you. Steve, it's about Bronglais really and the regional footprint that Bronglais has, and you said that you will be meeting with the chief execs of our Western partners. But what about Betsy and Powys? Because as we know, there are issues with discharge for Powys and Betsy residents that impact on our throughput through Bronglais.
Yeah, I mean, it's a good point. We do have the Mid Wales Joint Committee, the executive group that I chair, that has representation, senior representation from Powys and Gwynedd on that, both council and local authority. The social care element of that is on that agenda. We probably need to bring that back. We've just agreed the work plan that's gone through the Joint Committee. So it'd be helpful, I think, to bring back an update on that maybe in 6 months' time. It's in our annual plan about what we're doing in that regard. But it is recognised that it is a Mid Wales issue. I think I'm keen just to ensure that in the patient pathways into Ceredigion, which is a big part of it for Bronglais, that we've got the opportunities that we're seeing in Carmarthenshire and Pembrokeshire, that we're able to secure those in a way that is in the right context for Ceredigion, because it's a very different county, particularly around the number of community beds that it has.
Thank you. Mandy.
Yeah, it's. I'd like to pick up, please, if I may, and it's a comment, not a question for Steve, around the nosocomial COVID-19 inquiry, and just to highlight that on Tuesday of this week, the national interim learning report for the National Nosocomial COVID-19 programme was actually published. It is an interim report, and many people may have seen the Deputy Chief Medical Officer on the television this week talking about that and the learning that has been undertaken to date as a consequence of the situation that we've all been managing across the world. I think what I would want to say is that as an organisation, we've linked in and continue to link in on a national level with the learning that has come out of the report and contributed to that learning. But I would also want to offer assurance that actually from day one of the pandemic, and actually every outbreak, sadly, that we had to manage, the learning that has come out of each of those meetings has been shared across the entirety of this organisation. And the changes that we have made in practice have been as a consequence of that learning, rapid learning. So a number of those points are reflected within the national report that was published this week. It's the first of a number of reports that will be issued, available for the public. And I would urge people to look through it, because whilst it highlights some of the areas that we could have done better, it also highlights the learning that's been undertaken.
Thank you, Mandy. And I've just asked the board secretary, we'll circulate that report to board members. Thank you. Judith, then Mansell, and then Andrew.
Yes, thank you. I'd like to ask Steve a question about the further faster together. It's not referenced in your report, but the requirement is that this implementation is done through the RPBs, which, as you know, are not statutory bodies in themselves, but bring partners together. And requirement there is that the outcome should be the same across the region, even though the delivery may vary. So I'm seeking assurance that the plans will come through that route from executives and directors.
Yeah, that is certainly planned. At the moment, the last meeting we had with the council was about a month ago. And at that point, we hadn't completely nailed all of the governance and reporting, but certainly the intention is it will come through the RPB, as well as ensuring that both organisations are fully cited on what's going on. And then we'll do the same in the year too. So yeah, absolutely, that's the intention.
Thank you.
If I may pick up on that and looking at some of the other papers in the board, it's an opportune time to look at governance as a whole in relation to how we share with the statutory bodies, the 3 local authorities, ourselves, the composition of the IEG and how we're cited on that, how we report to the RPB. So I think this is the time really to have a look at the governance across, because it's quite complex at the moment, and I don't want anything to slip through the net.
Yeah, we'll pick that up. That's a very good point.
Thank you. Mansell.
Oh, thank you, Chair. It's more of a thank you, really, for the kind words that Steve and yourself said this morning. It's been a privilege to be chair of the whole of our CHC over the last 4 or 5 years. I think the important thing from us is that the Health Board has taken on board our concerns, our challenges, as you rightly said, and I think it's been a big help to the public. So thank you for that. Not every CHC in Wales has the opportunity to have speaking rights on the board, and I think that speaks volumes for this Health Board. So thank you. I'll miss the monthly chair meetings. And we sometimes haven't agreed, but at the end of the day, we've always had a constructive outcome, and I think that's the most important thing. At the end of the day, we're here for one thing, and that's for the public and the patients within Hull of Bar. So thank you ever so much. It's not quite over yet. I will be slipping across the class. I can see the groves already. But and I will represent Clyce going forward. And I hope the new chair coming in takes forward the CHC, or Clyce as it will be then, in the way that Maria has done. And of course, wish Paul all the very best as well, because I know that he was a keen member on the Comanche locality in early days, I think pre-COVID.
ABMU, yeah.
Yeah. So thank you for that, and all the executive who turned up and accepted the challenges of our executive, which has not been easy. So, but I think it's a learning curve all the way around. So thank you ever so much from the bottom of my heart. Thank you.
Thanks, Mansell. Thank you. Andrew.
Yeah, so thank you, Chair. My point was actually just to comment on the further faster part of the report as well. And it was really, I suppose it was just to try and save a bit of time later, because your members may have noted that in the operational update, we've provided a bit more of a detailed update in terms of further faster and what some of those principles are, and describe a little bit what the home first approach means. And just in response to do the specific point, I think from a integrated executive group perspective, we would absolutely, and of course we report into the RPB, we would absolutely see that the development of this work across the region is a key part of our business as we go forward, and so would be we'll be bringing that through and making sure we make those connections with his original plan.
Thanks, Andrew. It's really welcome to see a government policy reflecting what we are trying to do, and it enables us perhaps to go even faster. So that's great. Any other questions? Okay, is the board happy to accept the recommendations in the report? Many thanks. If we now go on to the report of the Audit and Risk Committee, over to you, Paul.
Thank you, Chair. As you see at the end of the report, there were 3 things that we're particularly raising as matters of concern. First is in relation to targeted intervention and enhanced monitoring. Obviously, one of the reasons why the Health Board's in targeted intervention is because of the financial position. And it's not clear from the letter that the Director General of the NHS issued to the Health Board back in December exactly what the expectation is of the Health Board so far as financial delivery is concerned to get out of targeted intervention. So the committee is asking for some clarification about that. So effectively, we all know what the rules of the game are. The Bluestone review is something that I've been keen to sort of progress. We've now had the report. There is learning which has come out of that, and it does also recognise the particular and specific challenges which faced everybody at the time that the contract was entered into with Bluestone. But there are some learning points which come out of that from a governance perspective. The third point about financial audit timescale is an issue really as regards Audit Wales and the possibility, probability even that they're not going to be in a position to complete the audit of the Health Board's accounts. So that the AGM can take place by the 31st of July. And it's to highlight that, and if that is the case, it won't be as a consequence of anything the Health Board's done. It's as a consequence of the resources available to Audit Wales. There is perhaps something I should have drawn some greater attention to, and that is embedded leases. The IFRS 16 is a new development, and it's going to affect, I think, the way in which accounts are produced. It's something which apparently gets the juices of those of accountancy persuasion running, and they're a bit like wild boar in the undergrowth, ferreting out truffles, looking for these embedded leases. So that'll be something that will come to the future iterations of the board. And I can see Claire's minute in that as I speak.
It's an image.
So thank you. That's the report. And I should also like to say I'd like to thank the support. I thank everybody who's supported me in my role as chair of audit committee over the last few years. But a particular mention to Joe, to Claire, and to Charlotte who've made my job immeasurably easier over that period. So thank you to them particularly.
Thanks, Paul. I wonder if we could pick up the expectation of our financial plan in relation to the government expectations. Is there clarity about that?
I might say a few words, and then I think the Director of Finance will want to come in. I think by way of some assurance, and I don't think there is complete clarity yet, at the last quarterly formal meeting we had with Welsh Government, there was much talk about de-escalation and what that would look like. So I think we've probably got more clarity now on the issues of finance planning and indeed the areas for which we are in enhanced monitoring. I think we need to continue to have those discussions, particularly around the finance, because as you will know, Paul, there is a huge difference in getting to 25 than making improvement towards and having a plan to get there in terms of timescales at least. So we are continuing to have those discussions. I know Hugh is in close contact with the finance delivery unit as part of that. But Hugh, I don't know whether there's anything that's happened since the quarterly meeting that we've had that might provide an update.
No further update from that position. I guess just reflecting a little bit, we were put into an escalated status because our deficit went out, and clearly as part of this year's plan, deficits across Wales are now going out. So there is a degree of consistency now being seen across the NHS as we deal with post-COVID recovery. But in terms of specifics on bringing ourselves back out of TI, nothing yet. I guess we just need to see how the land starts to lie now in terms of the consistency of positions that are coming out across Wales. And I imagine government needs to see that before they can make a judgment on the direction of travel and the pace at which recovery would be expected.
Okay, thank you. Any questions? Anna.
Thanks, Chair. This may be too speculative a question at the moment. Just thinking about the Bluestone review, I wonder if there's any learning coming from that may foreshadow what's to come in the wider code inquiry, and anything that we might be able to get ahead with. It may be too speculative, but I'm just curious about whether it's a sort of a dry run for something bigger.
Yeah, field hospitals will be one of the areas in the public inquiry. So we'll just think on that question and think about how we pull it together. That's okay.
Sure.
Yeah.
Thank you. Could I raise the issue in the report about risk? And it says in the risk assurance report that risks currently are exceeding the board threshold. What's the programme of work in our health board for risk at the moment?
So we had a long conversation at the audit committee because we put the R back in the audit and risk assurance committee, because one area we were concerned was we haven't been having as many in terms of the process around risk to the audit committee. So the chair asked us to bring a detailed report to the last meeting. So over the summer, what we need to do, Chair, because it's been a while since as a whole board, we've reviewed the tolerance and risk appetite. So there is going to be a piece of work over the summer with you all to do that, which will then affect the tolerance and appetite levels across the organisation, Chair. It just needs to be approved at board level first.
Okay, thanks, Jo. And it also mentions in the report the temporary variation order the Welsh Government may issue because of the delays with Audit Wales. Has that happened?
Not as yet, Chair. So we've had the manual for accounts has been issued, which does reference in there that Welsh Government may issue a temporary variation order, because we won't be in a position to be able to hold our AGMs, as the Chair of Audit Committee said, by the end of April. By the end of July, which would mean we'd be breaching our standing orders. So that's the plan. So they've indicated it in the manual for accounts. So we're hoping that will come out shortly, Chair.
Okay, many thanks. Any other questions? No. Thank you, Paul. If we go on to the report of the Quality, Safety and Experience Committee, Anna.
Yeah, thank you, Chair. So the report is as it stands. If I could just pick out a couple of things that link to other substantive items on the board's agenda today. The first on page 2, to note that we reviewed the quality improvement framework, and it's particularly gratifying to see the journey that this work has been on over the last 5 years, and how it really is starting to feel as if it's at the heart of our organisational ways of working. So credit to Andy, Hugh and many others for getting us to that point, and we'll hear more about that later on. Secondly, we spoke about the review in epilepsy and neurology and LD, and it took us into a wider conversation around fragility in our services, and so it is particularly gratifying to see today that we have the clinical services plan on the agenda later on, and I think that will be a really important discussion for our board to have today, and will continue to be of significant interest to our committee. And then finally, I would have asked Mandy to comment on the HIW report around Angrily ED, but as usual, she is ahead of me and has covered that sufficiently, I think, already. So happy to take any questions on the report. Thank you.
Thank you. Any questions? Mandy?
It's not a question, it's just a supplementary to the comment that Alan has made about the fragile services and some of the risks that we are managing within the organisation. And Andrew actually has initiated a piece of work, because we agreed that at our next quality committee, we would actually have a paper on our fragile services and the risk that we're running. It will also link in with the work that Jo has just mentioned around our board appetite around risk management. And earlier this week, Jo and I talked about how we revisit some of the risk discussions that we have with our operational services team to make sure that those risks are as accurate and as up to date as they possibly can be. So it's just to reassure people that we are actually undertaking that work on a continuous basis, but also we've stepped it up a level as well.
Thank you, Mandy. And the report also raises concerns about neurology and tertiary pathway and the closure of a service due to retirement of a member of staff. I wondered if we've been able to do anything.
So I was going to say a few words. I think the Director of Governance may wish to come in as well, but good to see us here today. A couple of points, I guess. The exec team has got a work plan for the coming year, starting on Saturday, which will include a regular review of the board assurance framework, really from 3 points of view. So made up of 3 elements, the board assurance framework for me. One is the measures, so how are we doing against our strategic objectives, and reviewing, are they going in the right direction? If they're not, do we know why? Is it because our planning objectives are not pushing us in the right direction, or is it a lack of something else, or is it something we need to think about? The principal risks that underpin that, and that could stop us from making progress, and our mitigations for those things. And then a review about where we are with our planning objectives, which are the short-term measures over the next year, up to 3 years, that are going to try and push us in the right direction. That will all link to a paper coming to board in May that I'm doing around the replacement for the transformation steering group, because trying to use the board assurance framework going forward as a way of thinking about innovation, about where we may be struggling to reach some of our ambitions set out in our strategic objectives. Who can we learn from? Who can we bring in to help us? And how can we think differently about those things in a transformational space? So that will all link together for us. Today is largely about the current annual plan and where we are in relation to that. There is a refresh that will now go on with the board assurance framework linked to and subject to board approval of the annual plan for next year. That's underway. And there will also be a closure report for all of the planning objectives that are currently in our plan for 22-23, so that the board can see clear line of sight on which planning objectives were achieved, which are still ongoing and where they've gone, and which we may be choosing to do something else with, so that there's a complete audit trail there. It's here for noting today, but I particularly want to note that the exec team is now using this on a regular basis to both ask about progress in the short term and keep our eye on the longer term ambitions that we set out in our strategic objectives.
Thank you, Steve. It's moved a long way from the time that during COVID when you looked at how many decisions
458
that the board had made, and with some floating in the air, many, I'd say hundreds. So thank you very much. Jo, would you like to add?
It was just to add from a governance point, Chair, that all the planning objectives have been through the committee since the previous board, and also before the paper comes back to the main board, the closure reports will be going back through the individual committees. And it just the BAFF is showing you this time that there's 9 POs which are behind schedule, which is a slight deterioration from the last board, but 7 are now complete and 3 are ahead, and there's full details of all those within the paper, Chair.
Thank you. Any questions? Maynard.
Thank you, Chair. On page 3 of the report, looking back on 22-23, it talks about the PADR and the linking of those to business objectives and departmental objectives. And 60 to 70% of our staff agree that that's taking place. Just wondering how we engage the 30 to 40% and what we can do to improve those figures on PADR. PADRs are not popular, but either by managers or by staff. So I'm just wondering what we can do around there. And the second one is really just a comment on one of the business objectives, that 5O, which is the stroke strategy. We do have a business case for a comprehensive regional stroke centre coming to the Strategic Development Committee in April. So that is moving forward.
Great, thank you. Lisa.
Okay, thank you. So with regards to PADRs, we have got a training programme that has been rolled out through our OD team around the benefits of a PADR. So rather than focusing on the paperwork and what we expect people to do, it's actually what are the benefits from having a PADR, and particularly then the performance and development element, which links in with the business objectives. We have got a staff story going to people committee next week from a manager and a staff member, where the manager has been through the new training programme and how it's completely changed the way they undertake a performance review, and how the employees benefited from that different focus on the programme. We have had 21 directorates in the past 12 months where we have seen an improvement in the quality as well as the quantity of PADRs, and that represents another 730 staff who have had a PADR since we've started to roll out this training programme. There are workshops being arranged as well as the development programme. So there's a series of interventions through the OD relationship managers to highlight to everyone what the benefit of the process is. So we are focusing on quality rather than quantity, because it's very easy to instruct people to have one and you tick a box. This is about how do we really make it meaningful for our staff and our managers.
Thank you.
Thank you. I see a lot of nodding heads around the table, Lisa, on the quality rather than quantity. Any other questions? Okay, thank you. The board's happy to accept the recommendation and take assurance from the report. So the next item on the agenda is the update on the annual plan. Over to you, Lee.
Yes, thank you, Chair. So I'm pleased to bring on behalf of the executive team the annual plan for 23-24, which is the document that sets out our priorities and objectives as a health board for the forthcoming 12 months. The board members obviously been very much aware of the development of that over the past 4 to 6 months or so, and our evolving approach to planning in general. The context of the plan is, of course, a very challenging one. We obviously are in targeted intervention, as mentioned, for planning and finance. We do continue to respond to a pandemic and, of course, recover for the impact of the last 3 years associated with that. And as has been mentioned, we continue to have fragile services whilst we implement our strategy. So we agreed in January board that we would not be in a position to submit a balanced 3-year financial plan, and therefore the Chief Executive submitted an accountable officer letter at the end of February, setting that out to Welsh Government. In this context, the plan is seeking to achieve 2 things broadly. Firstly, set out what we can do over the next 12 months to improve services for patients and our public within the resources and the capacity that we have. And then secondly, set some foundations for us to chart a broader trajectory of improvement over the next few years to improve both the financial position but also the service delivery. As part of our planning, board members will note that the work we've done to narrow the number of planning objectives, and the intention behind that is that we can be more focused on those that we have identified in the plan, and therefore ensure we have more detailed plans and clearer on our outcomes. I would say, I suppose, speaking personally, I think the plan and our approach to planning is continuing to develop. So from my perspective, I don't think we're quite there yet on where we want to be, but this is an evolving process, and aligned to targeted intervention. I think we are working hard to put those key building blocks in place and hopefully moving in the right direction, linked to that work that's being done through TI. So what we're asking board to do today, recognising the challenging situation we're in, and therefore what we're able to do and not do within the plan, is firstly approve the planning objectives, which are important to set the direction for us as an organisation, and then secondly to approve the overall plan for submission to Welsh Government, albeit acknowledging that this is a plan at a point in time, and we recognise our current forecast financial outturn is unacceptable, so further work will need to be done over the course of the next 12 months. So I was going to stop there, if that's okay, Chair, but probably Hugh, we may want to add some points on the financial forecast.
Hugh?
Thank you.
Thank you, Lee.
Good day, Liz. And thank you, Lee. And just to add a couple of things and build on Lee's points. The deficit plan for the year is within the plan at 112.9 million. Now, that's clearly in an acceptable position, and indeed, if it was anything else, then we would probably be talking about a 3-year plan. So clearly we are in an acceptable position, but it does represent the expenditure rate that we are currently seeing within our system. So there is a sense of realism around that figure that we're proposing and putting in. And there is inherent in delivering that a 19.5 million savings requirement for us as a board. And we're currently working through gaining greater assurance over the delivery of that 19.5 million. We've got line of sight now to delivering a figure within that broad quantum, but as yet need to do more work to build on the detail and to provide greater assurance that we can indeed achieve that. Some of that may well be dependent on non-recurrent opportunities, which is disappointing at this stage, but we'll build on that to over Q1 to provide that greater assurance that we can deliver it recurrently. That's the critical issue for us, is recurrent improvement. As Lee alluded to, an accountable officer letter was sent in, and the response was around the finances, as I would have expected, in terms of recognising that there are challenges in the system, but also recognising that there is a financial challenge across the NHS that needs to be addressed. A crucial point for us is clearly with the deficit this significant, that gives us a cash implication. So at this point in time, we would not have sufficient cash to pay our liabilities in the last 2 months of the year, February and March, and we'll obviously be working with government to gain greater assurance over our ability to work on that over the final quarter of the year, and indeed any mitigating actions that we need to put in place locally. But that is an important point to note at this stage. And just to note as well, an error on page 2 there, where planning objective 5C has been allocated to the Director of Operations. I can assure the Director of Operations that I'll take that one on. I'm sure he'll be relieved.
Okay, thank you. Questions? Maynard, Judith?
Yeah, it's a general question. But
sorry, can you pause a minute? Thank you, Maynard.
Right. It's a general question really about the overall plan and our confidence in actually delivering that. He was already mentioned the savings. That's been of grave concern over the 3 years that I've been in IM. I don't think we've ever achieved our savings target. So confidence in delivery of savings and confidence in delivering the planning objectives. I think it's great that we've managed to refine it down, and I strongly support the objectives that are there. But I just wonder about the degree of confidence in our executive officer of actually being able to deliver this plan and get some confidence from the Welsh Government on this area.
I'm happy to respond. You start off. So I guess on the general point first of all, and then we might want to pick up some of the savings more specifically. So I think what we've been striving to do over the last few months is as part of narrowing down that focus into some key areas, then get into the detailed delivery plans associated with each of those. So, and I guess to some extent that's proportionate. So where we know we've got bigger plans that are more material to the delivery of the overall plan, we've spent more time getting into them. So I think I guess linked to what I said earlier, I wouldn't say we're completely there yet. I think there's always ways in which you can improve that, but I think we understand our position and we understand what needs to be done to deliver each of the key planning objectives, and we have I guess a line of sight to delivering them. There's always a balance to strike, isn't there, between being ambitious or wanting to deliver as much as we can whilst being realistic. And I think the time we've invested in getting underneath each of those key plans has given us confidence that we understand that trade-off, if you like, and therefore I think we've got a fair degree of confidence overall in the plan, but recognising obviously when you're stretching yourself that there are some risks inherent with that. So I guess that would be my overall response, but there might be a more specific one as well.
I might come in as well, and then Hugh might want to comment just on the savings, and there are some things going on there. I think the only thing I would add to what Lee has said is that I think it's going to be really key to our escalation status, that we set out what we're going to do and then we do it. And I think that's going to be particularly important for us in quarter one and some of quarter two, given when the national meetings happen around escalation. So being really convinced up front was, as Lee's absolutely right, balancing doability with ambition and trying to get that right is going to be really important for us. And I think as a team, we've looked each other in the eye and we think we can do this. On the savings, I think that there is always a degree of risk around those. And as the Director of Finance has mentioned, some of it is non-recurrent, and I think we've got to do more in quarter one to recover that recurrently, so that we have some headroom in the position. The position we've set, and of course we will need to talk to Welsh Government about this, we think is doable overall when you look back over our history of ability to make savings, albeit largely non-recurrently, I would say. We've been able to deliver this level of relative level of savings over the years, so there's some confidence in the top level number. However, I think where we've got this year where we haven't been before is we've now been looking at not just the number and our confidence in that, but the governance that wraps around it, the leadership, the team that's behind it, the things that will make it happen. And I've asked the Director of Governance as a sort of final act now that the plan is largely together, to go through all of that with each of the members of the executive team who've got a leadership role in those savings, to ensure that we really know where our biggest risks are in any of those domains, so that we can work on those immediately and make sure that we've got our best people, best leadership, clear line of sight, and a really clear idea about where that money's going to come out. So it is still risky. There are still risks in it, but I think the level of grip and confidence, both at the exec team level and down to our teams, is in a far better place than it was when the pandemic was taking up so much of our time.
Hugh?
Yeah, good day. Just a couple of reflections. I think over the last few years, clearly delivering cashable savings has been a challenge, although there's been an awful lot of work to deliver productivity gains across the system. So I can point to heart failure, where there's demonstrable evidence of about £1.2 million worth of productivity gain, cellulitis about 1.8 million, patient-initiated follow-up work 4.5 million, and upwards. So there's clearly been an awful lot of work to deliver gains within the system. What we have really struggled with is to transact those in terms of cashable benefits. And I think we're in a much better position now with the tools that we've got corporately. So it's just there, but Equip is one very good example. Value-based healthcare, the work that we're doing in digital, the work within OD, which is changing the culture within the organisation. So many of the tools are there, and the diagnostics has become better. But I think the challenge for us now is to move from diagnosing the issue into a delivery space where we can see that this can be transacted with a route to cash, and that's the bit that we now need to get right over the coming few months.
Okay, thanks. Can I ask one
Yes.
follow-up question? We are in targeted intervention because of planning and finance, and I know that Sally Atwood has been doing a peer review. Just wondering when we'll get a report from Sally on that.
So the latest updates, we're expecting that report to be with Welsh Government shortly and should be signed off within the next couple of weeks. So we'll bring that through SDOD and obviously the intention was to bring a more comprehensive update on target intervention, probably the next board meeting where we could bring that and the other pieces of work we're progressing.
Thank you. Judith, then Rodri.
Yeah, thank you. My question's on a slightly different point. I'm interested and want to sort of hear about how you're looking to achieve a synergy across all of the planning objectives. So if I think about the one around integrated localities and accelerated cluster development, that can really only, in my mind, really fully develop if acute services, supply care, the emergency care are thinking about how their services will look differently to enable more to be delivered in the community, and the same I'd say around all the population health plans. So I'd just sort of be helpful to understand how that synergy is going to be achieved to make sure people aren't, in delivering their planning objectives, doing something which hinders another planning objective. Hope that makes sense.
Yeah, no, that does make absolute sense. So I'm happy to take that question. And I think that question touches on probably where we haven't been strong over the last 12 to 18 months, I would reflect. So I think what we have done is had people progressing individual planning objectives, and obviously each of those have largely progressed as per the plans as they were set out. But that opportunity to maximise the opportunities of working across planning objectives and achieve that synergy, I think is perhaps the area we haven't achieved. So what we've been doing as an executive team is devoting more time through our Wednesday sessions to really getting into those planning objectives, understanding the synergies, explaining where we are each individually with those planning objectives, and then exploring where those opportunities exist. So we're going to continue to do that, and we're setting out a programme of work now so we can focus, and that's the benefit, I guess, of having fewer planning objectives. We can spend dedicated time in a programmed way to talking about each of them and exploring those synergies with the wider teams then as well that are delivering them on our behalf. So we will do that through the next 12 months. And then the other mechanism we've got, which is picked up in the clinical services plan paper, is the multidisciplinary professional forums we've established. So that will be an opportunity for us quarterly to bring the senior leaders across the organisation, circa 150 people, together to have a broader discussion about what we're doing in each of these key areas, and at points then we'll look to have dedicated discussions on some of those key topics. So I think the ones you've picked, for example, are the ones we'd really want to devote some time to. And in those forums, just to finish the point, what we're very keen to do, as Jill and I were talking about earlier in the week, is not have secondary care conversations and a primary care sustainability conversation, or whatever it might be, that actually we have mixed groups coming together to ask the question, GPs around the table when we're talking about critical care, secondary care consultants on the table when we're talking about primary care, so that we get that system view of everything we're doing.
Yeah. That's brilliant. If I could just come back, and some colleagues around the room will remember we did that with our cluster leads and secondary care colleagues, and there was some real challenge about the thinking of how things work within an acute setting and how it looks from a primary care perspective. So I'm really pleased to see that's taken forward. So thank you.
Thank you. Rodri, Anna, then Joe.
Yeah, thank you. I think you've given a frank and honest reflection of of what the annual plan will be for the future years. But it's just looking at page 2, obviously you've stated quite clearly there are risks to this. And if you look at the third point in the assessment, it says the majority of plans are based upon existing resources with a nursing workforce stabilisation programme, the main exception. How we need to sort that out, and I'm just thinking, how would that kind of, I don't know, reflect or kind of regarding the plan itself financially, kind of, obviously we are reliant on bank nurses but I'm just thinking to get more stabilisation in the workforce, kind of, will that impact on the financial plan? And how would it be negative or positive, dependent on the kind of the staff that we're recruiting?
Yeah, so I'm happy to give a kind of brief response, and then I think Lisa probably pick up the specific if that's okay. So I guess what we're setting out there within the paper is that we've had to make some difficult choices this year, given the context, and I suppose we've been very disciplined in saying we are not looking to develop new services or expand services where we're needing to make the best of what we've got essentially and maximise the capacity that we've got to deliver services to patients. So in that regard, we've not within the plan set out additional investments into services, and therefore we've also not made assumptions about additional workforce going into services, because equally that is a constrained resource as much as the finance is a constrained resource. So what we're highlighting there is that the only exception to that of any significance is the nursing workforce stabilisation work, where we are continuing to invest in bringing overseas nurses in, and obviously the apprenticeship scheme and so on. So that brings with it a short-term financial cost, but a medium-term financial benefit, and Lisa can expand on that now. But it also is us then saying that the workforce that we can get hold of, we're going to direct them into filling the deficits we've got on wards, recognising the issue that gives us from a service sustainability, quality and safety point of view, where we're so reliant currently on bank and agencies. So that's what the paragraph is describing. But at least I don't know if you want to expand on the workforce stabilisation work.
Yeah, so what we did this year is we changed our approach to how we would look at stabilising the nursing workforce, and we focused all of our efforts onto one site. Therefore, all of the overseas recruitment were particularly focused there. So we set ourselves a target of 100 nurses. By the end of the year, there will be 117. So we know the methodology works. The plan that we have now is to complete England Willey by May, and the next cohort of overseas nurses from May will be going to Pembrokeshire. Accommodation was a problem. That was a risk to that plan. We have accommodation that has been found, so we're just in the process of securing accommodation. So everything is still online for our next stage to move. What we have seen in England Willey is a reduction of vacancies from over 100 to, at the last count, was 38. March is always a time of year where we have more people leave because it's a natural retirement date. So we know that's built into the plan. And therefore, all of the indicators are that this is the right approach. We are seeing a reduction in agency workers, and from the beginning of April, we will be introducing a ban on one of the premium agencies on that site, with a further rollout in May. The feedback from the nursing teams in Glangwili is that it is making a huge difference, as well as financial. There is also a massive benefit in this work in terms of work-life balance, so people actually feeling more in control and able to do the things that they need to do to care for their patients. So therefore, we are confident in the plan that we have drawn up for next year that we will deliver.
I think that's a positive for the board, isn't it? And I think it's kind of very welcome. The agency nursing, we need to kind of grow your own, but also kind of get the nurses into these hospitals. So thank you.
That's great to see.
Just on that around money, it is built into the savings plan that there is a significant saving being contributed by the work that Lisa and the team are doing.
Thank you. Anna.
Thanks, Joe. My question actually fits quite neatly with what Lisa's just been describing. I think of the annual plan as being a theory of change, really. We're saying that if we do these things, we'll get these benefits, and life will be better. And I'm just wondering, as I enter my 6th year soon as an IM around this table, have we tested this theory of change with the people who are the sort of the target beneficiaries? So we could take our staff as an example, but obviously there are other stakeholders in this as well, to really test out whether the things that we have decided are the things that are going to work, are the things that would make a difference to those people. Either by talking to them directly or by using any sort of sources of intel we have that would help us with that question. And then leading on from that, kind of what space are we building into this planning process for reflexivity to iterate what it is that we've got at this moment in time, bearing in mind we're bound to be learning as we're doing. So I wonder if someone could take. Okay.
So speaking around the workforce areas, this is absolutely owned by the service and is led by the service. So we have taken a very different approach of we are not coming in and solving what we think are your problems. We have a meeting that takes place every week with the general manager and the lead nurse on the site. We talk to them about the things that we are thinking, but they are the ones that say to us, can we do this here? Can we do that there? Can we look at the rosters here? So basically the central workforce team is responsive to what the needs of the service are. So we will shift our plans linked with the service lead. So it is very much owned and controlled by them. The Ward Sisters are meeting regularly as well with the general manager and the rostering team. So again, when there's anything around flexible working, how do we support individuals with that? The cycle that we have in the workforce team is that Dan Owen is leading the first piece around the placement of the overseas nurses, the support around how we manage the individuals in the workplace. When he then moves into Withybush, another team are going into Glangwilly then around how do we now improve stability. So once we've achieved it, how do we then continue with it? So they will be supported by a different team then, but it's very much led by the general manager and the lead nurse.
I'm going to bring in Steve as well.
Gave me time to think because I was just thinking when I asked a question like that. I think Lisa said this right. I think when you look at the question around theory of change and testing the staff, I think it's fair to say these planning objectives are mixed from that point of view. And the reason I say that is if you look at things like transforming urgent emergency care, the workforce plan, decarbonisation, there's very different things. Actually, they have been developed very much. The teams telling us what we need to do. We've broadly said we want to work in these areas, but the teams have responded to that. But when you look at something like the digital plan, which is going to come to board for a discussion in May, I think we're at an earlier stage for that, which is what is it that we think we're trying to achieve, and then how do we engage people, and what I hope will be a really exciting discussion. So I think it's a mixed bag. Some of this is about change, and some of this is about developing plans for further change, and we've got to try and strike that balance right so that we are focused on the medium term. And on the sort of reiteration part, I think that for me there's that links to what I said around the BAF, the board assurance framework, which is as part of our review of that, it's seeing where we are with planning objectives, what we're learning from them, what's worked really well during the year. This is the exec work programme now for the next year, and having regular time where we can come together probably around a group of planning objectives rather than single ones to say, how is it going? Is it working? Other things we should do. And then at the next level up, are those things having an impact on either the principal risks that we're handling or our strategic objectives overall and the measures that we put in place for those. So I think we do have a way of trying to ensure that we push on with keeping ourselves poised, because planning is a process that we all need to fall in love with, as Lee keeps saying, not a product that we sign off at the beginning of the year. So I would hope that what the board will see, this being the starting point, and then what's coming in May around the closure report, and then further updates on how we're doing around board assurance and the planning objectives, will show that this is an iterative process fundamentally.
Thank you. If I can bring in Joe, Paul and Anne, if we can keep it succinct, because no, you're okay then. Joe and Paul.
It's just going to really brief, thanks, Chair. It's just going to really briefly go back to the question around the plan objectives working together and how we're linking those in. I think there's huge strength and benefit to having.
Excuse me, Joe, could you use your microphone?
Apologies.
No
Sorry.
problem.
Sorry.
Camera can't find it.
There we go.
I'll shout. Yeah, just to come back to the plan objectives and how they're working together. I think there's huge benefit and strength in having everything written down in this way. And I think there's been no doubt that previously there has been a lot of crossover that sometimes hasn't been recognised, particularly from a population health perspective. And already we found that having the plan objectives set out in this way, we've got we've got an agenda around One Health, and we're driving some work around that, which obviously fits. We've moved that into the sustainability agenda and working with Lee on that. So I see this as a tool, not just a plan, but a tool that challenges us to look across all of the plan objectives, not just our own, to see where our teams can be inputting. And I know from the public health perspective, it's particularly relevant at the moment because we've got the team that's just transferred employment into the health board, can now work to one organisation into Health. So we'll be able to look across the whole breadth of the plan objectives and see where the population health team can benefit them.
Great, thank you, Jo. Paul?
Yeah, just briefly then, Chair, I think just an observation first of all, I think that it's important to recognise that this is not the first iteration, it's the first time that we've seen this plan, and there's been an awful lot of discussion which has taken place amongst all board members before the plan is presented to the board today. And just as an observation from my perspective, that discussion has probably been the most inclusive and the most discursive that I've participated in during my time on the board. So I think that it's been a much better process this time, and a really good discussion has taken place about the contents of what's in this annual plan. Having said that, I think it's important that, as Steve has emphasised, that we do what we say we're going to do. And in that vein, we've got £19.5 million of savings. Just to put that in context, I think in this year we've struggled to do £1.5 million of recurrent savings. So the ask next year is to do more in 1 month than we've done in the whole of this year. And that sort of begs the question: well, if we can do it if we were anticipating doing it in next month, why couldn't we do it in March? What's changing? The third observation I'd make is, to what extent are we getting back to the sort of productivity, talked about the improvement in productivity, to what extent are we getting back to the same level of activity as we were able to deliver pre-COVID within this plan? And my final point would be in relation to the recommendations, and just to check that the second bullet point is accurately reflecting what the extent of our power is today, given the extent of the deficit that we're writing into this plan. Are we in a position to approve the annual plan, albeit with the caveats that are in there? So just checking that that's the right form of words, really.
Okay, yeah, thank you, Paul. Who would like to take those?
I might start, but others might want to come in here, as always, Paul. Really challenging questions, but I think the right questions. And if I start with the finance, the one, and you're right, this is a step change in our delivery. However, when I look at the plan around the 19.5 million that we've got in place, I think the first thing the board can take some assurance from is that a number of those things are already in play, and we're starting to see some of the benefits. So Lisa mentioned the fact that we will be instituting a ban on some of the high contract agency. We've seen in Glangwili the use of agency dropping as a result already before the beginning of the financial year. So there's already a pathway that should start to deliver more as we go into the new year. On the transforming urgent emergency care work as well, we've seen a huge amount of change, albeit sometimes hidden by the demand at the front door that we've had during the winter, which has absorbed some of that benefit. But we're starting to see now we can demonstrate that we are seeing bed equivalent savings coming out of that, and it's how we transact those, as the Director of Finance says, which is a challenge. There are a range of other ones. Of course, some of the non-recurrent ones will be in place, but we've got a number of other ones which will be, which have got clear plans about when they start, which should build during the year. So I think it is the right challenge. I think the question for all of us is, how do we ensure that the board is very clearly cited on delivery and how it's playing out? And as the Director of Finance has already alluded to, we're not stopping with the 19.5 million. There are a range of other things that are in our thinking, which, as we know, in year things happen. And last year we had particular challenges around some of our prescribing, for example. So having the ability to be able to deal with those in year without moving our financial position means we have to keep pushing on all of those things. Probably Andrew might want to come in on the pre-COVID levels, because I think it's complex, because in some areas the system's changed so much it's difficult to measure pre and post. And then I might ask the board secretary just to come in on the approval.
Sure.
Thing.
Andrew.
Yeah, no, that's fine. So in terms of pre-COVID levels of activity for outpatients, we're pretty much back to where we were pre-COVID now, or will be in April. We're more or less at our pre-COVID levels. The additional productivity that the plan describes and the financial plan describes is around the improvement work we've been doing, in particular around reducing the number of follow-up appointments and we need to undertake. So there's some real transformation work gone on there, and the plan this year is just a continuation of the work we've already done. And I think our quantification of that for this year, as Hugh was saying, is certainly in excess of 5 million in terms of capacity that's put back into our system to reduce waiting times. So I think we've got confidence in in a number of those actions. In terms of our elective productivity, we're probably still at about 70 to 80% of where we were pre-COVID, and we've got a significant challenge around our workforce position, our deficits across our theatre areas and elective services, which is what is hindering us at the moment, making that step back towards 100%. But there are plans in place, and the teams are working with Lisa's teams to really push on that workforce to improve that workforce position. I think we can also see evidence as well in terms of improved productivity through some of the capacity we have restarted as well. So there's a two-pronged element to those levels of activity. Things like diagnostics, although we continue to have challenging waiting times, you'll see that in terms of activity, we're now undertaking the same level of activity we were undertaking before COVID across our radiology services, for example. And for things like cancer, we're treating as many people as well. We're treating more people than we've ever treated before. So there are, I think, as Steve said, it's a bit of a mixed position, but we're sitting on Julie. Just one other thing, just on that, in terms of some of because you mentioned urgent emergency care there as well. That's obviously a key component of our plan. I think and Lee touched on it earlier, I think one of the things we've done this year, and it's certainly the most granular version I've seen in the 3 or 4 years I've been here, and certainly the 3 years I've been in this post. Been here longer than that, haven't I? I'm just thinking about this job. Sorry about that. But I think there's a different level of granularity in our planning and our thinking. I think we do have a much clearer understanding of what the baseline is, what improvement we've seen, and what further improvement we need to see from that to start delivering the benefits in the plan. And we can almost there's still some work to do, but pretty much we can do that by site down to a level of, so if we see a 4% improvement here, we'll start to see that fall out in all of the outcome domains that we're tracking. So there's I think there's a different level to the detail that we've got this year.
Thanks, Andrew. And Jo?
Yes, Chair. So you can see the wording in the recommendations being carefully worded, actually, and that's been through with the Director of Planning and the Director of Finance as well. We have to approve the delegation of the budget today, otherwise we can't operate as an organisation, and the Director of Finance wouldn't be then able to delegate the budgets out. What we need to be reminded of as a board is we are breaching our statutory duty in relation to planning. This is why we're asking the board to approve an annual plan, recognise the risks, but fully aware that Welsh Government may not accept the plan. So as a health board, it gives us a remit to work within, but very conscious that this needs to be submitted to Welsh Government today with an accountable officer letter, and then we will receive feedback whether it can be approved or not. But as an organisation, we need to be able to operate, Chair.
Thank you. Hugh.
Chair, I was going to get on to the requirement to delegate the budget formally, but it does relate to a question that Paul raised about what's different between March and April in terms of the ability to generate savings in April that we couldn't generate in March. And I think that's an important question, and it relates to the step change we've seen fundamentally. So last year's budget was still at the 25 million mark. So any shift in our expenditure just changed from where we initially forecast at 67 million down to 59 million. So that wasn't recorded, accepted as a saving. We are now going into a position where we're recognising a new baseline. We're recognising that our expenditure is at that level, and therefore everything that we will do to improve that position will be counted as a saving, as an improvement in our position. So that mathematically, that's how it works.
And Steve?
Do you like a bit of maths? The only other thing I wanted to make, because I'm not sure it's implicit in the plan, but I'm not sure if it's completely explicit in links to discussions we've had both today and at earlier boards, is a lot of what we are predicating, particularly our urgent emergency care plans on, is no further deterioration in social care or domiciliary care. And that's why I think it's important that as part of our performance reporting through the board, that we start to have sight of what's going on there, because I think, again, one of our challenges was the further loss of that capacity last year, which really pushed our position out. And we know how much of our deficit, because we understand the drivers of our deficit are driven by the medically fit, ready to leave cohort. So I think it's just worth the board knowing that we've had to base this on an assumption, but we'll keep reporting back on whether that assumption remains safe.
If I may ask a question building on what Paul and what Maynard said as well. Within the planning object, well, we are in targeted intervention, enhanced monitoring, primarily because of finance and planning. In relation to finance, there's an objective in the annual plan, 8C, for the long-term roadmap for recovery. There are no timelines. And I think it's important as a board that we nail that down as to when we can expect to see a plan, however it's formed, before board. And then the other question I have, taken into account what's different this time, how are we going to deliver those savings in this opportunities framework when we haven't previously? And I wondered if you could give me assurance that you're assured that there is sufficient governance within the delivery teams that you're cited on, and that you are assured that they have the trajectories, they have the plans, they have the granularity that we've heard from the service plans to deliver this. And we as a board, through you, will be cited on where there are the issues, where they are delivering. I just want assurance that there is that hinterland behind the governance that will make a difference this time to the delivery as compared to previous years.
Thank you, Chair. Just in terms of the roadmap, we absolutely need that back to board to have it, and that needs to be, to come back to Anna's point earlier, quite a discursive and iterative process that we follow through. We absolutely need that before the next planning round. So I'd see that needing to come back in September, October time, just to get it formalised. In terms of the governance arrangements, so two different elements to this, I would say. We have the programmes of change that we're working through, and there's more work to do to make sure that the governance arrangements are right there. So TUC as a programme of change, for example, and nurse stabilisation is another key programme change. There is more work that we need to do to make sure that the governance is as robust as we can possibly make it. And then the other side then is more within the operational framework that we've got as an organisation, and our Improving Together meetings. We've now, on our second iteration of those Improving Together meetings, is the opportunity for all of us as executives to work with our operational directorates and our corporate directorates to understand where people are against their plans, how they're delivering, and what further support is needed corporately. Probably a good place to reflect back to is the ongoing work we've got with our TI framework and our review of the KPMG recommendations, which came out pre-COVID. And there are some elements there that we still need to work through, particularly around the alignment of support that we are able to provide to those key programmes of delivery.
So you're more assured for the forthcoming year than you have been previously?
More assured, but there's more work to do. Okay.
And in relation to the roadmap to recovery, you say September, October. Are we going to be part of that iteration? Because that's when I'm going, and I want to see this roadmap to recovery and be part of the design of it, as we have been with the annual plan consistently. So perhaps the next board seminar, we can start that process.
As I say, this will be an iterative document that we work through. So yes, absolutely fine.
Great, thank you.
It would be September board chair.
Okay, thank you. Yes, I want to see this. Thank you.
We'll make sure it's in September board.
Okay, thank you very much. Any more questions? I know this has been a very long discussion, but it's a really, really important discussion. And I'm just going to do a brief summary before we go to the recommendations. One of the points that you made, Steve, at the very beginning, we have to deliver what we are saying we are going to deliver. That is so important for confidence and so important because this is our promise to our population and we've got to keep our promise. It's good to see that the planning objectives are more focused and there are less of them. And as everybody has said, we as a board have debated this for many, many, many months. It's not something that's just come to board today, so it belongs to all of us. I welcome that the board secretary is going to take a role in the level of risk, because that goes back to we have to deliver what we promise to deliver. And it's wonderful to see the nurse stabilisation and finding accommodation in Pembrokeshire. Wow, it's just great. You know, you've got a career after this, you realise that, don't you? And picking up on Judith's point, you know, this is one strategy that we have as a board. It is one system and it is one budget. So that bringing together and that interrelationship, and it all needs to come here and it needs to be coming together out there as well. So on you know, the basis on that brief summary, and I really welcome the questions that you've all been asking, and I look forward to the delivery this year in every way. And so is the board happy to approve the recommendations which are set out at the end of the report? Yeah. Okay. Thank you. Okay, we're going to go on to the next item on the agenda, and that's implementing a healthier Mid and West Wales strategy. Lee.
Yes, thank you, Chair. So obviously we bring regular updates to the board on the strategy. So board members will be quite familiar now with where we're up to and the 4 key areas of work that are being progressed as is set out in the paper. So I'll just briefly summarise where we are in relation to each of those. The strategic outline case is well underway now, and we're aiming for completion of a draft of that by the end of June. That is, of course, subject to the clinical review being completed, though, which I'll come back to shortly. Technical work on the land is also progressing well. The 2 areas of, I guess, most interest to the board would be the clinical review that Welsh Government are procuring as part of the strategy. As we mentioned before, that's a standard part of the process now, and Welsh Government were looking to procure that on behalf of both ourselves and Cardiff and Vale Health Board. Unfortunately, no bids were submitted ahead in time for the deadline. So we are currently seeking clarification from Welsh Government on the next steps in relation to that, and obviously our concern is around the timelines and impact on that. So we'll certainly keep board members updated on that, because that is a critical piece of work for us now, which we're hoping to have had completed shortly. The land consultation is, of course, well underway as well. So we've had nearly 600 members of the public and staff attended our events in the first 6 weeks, and we've had over 200 questionnaires completed to date. We held a midpoint review on Monday to look at the success of that consultation process and the engagement, and further events are going to be held now, particularly targeted at the underrepresented groups, on the basis of the evidence we've had so far on attendance and submission of questionnaires. I would like to just pass on my thanks to members of the board and the teams, the wider teams within the organisation, for their willingness to attend these events, and particularly given the current pressures that everyone's facing. So I guess the key summary is we're on track, I would say, with the land consultation for the summer as we'd set out, and the tactical work for the land, but clearly the clinical strategy review has slipped, and that therefore is a risk for the summer timeline that we anticipated, and by virtue of that, it presents a risk to the sign-off of the strategic outline case as well, because we're progressing the work and we will have a draft, as I say, by June, but clearly we'd want to reflect the outputs from the clinical review in that strategic outline case before bringing it back to board and submission to Welsh Government. So that's the position, Chair, and happy to take any questions.
Thanks, Lee. Rodri and Phil.
Yeah, thank you. Yeah, so regarding the midpoint review and the consultation, I've been to quite a few, and I have to say I think it's come over well with the public. But what did you learn from the midpoint review? Are there any kind of differences or any tweaks that you need to do midpoint through the consultation to ensure that we get full kind of dialogue with all those concerned? And I'm just thinking, has anything come out of the midpoint review?
Yeah, and I may want to pass comment on this as well. So the purpose of the midpoint review was to look at, so the organisation we're working with, ORS, is supporting us with the analysis of the information that we've had to date. So we're recording who's attending the events and some background information about them. So we've got a sense of the extent to which we're reaching all parts of our communities. And then obviously we're also able to analyse the questionnaires that have been submitted as well. So what we've learned from it is we've had a look at that information split in different ways. So the geographical split, and that's informed then where we're targeting the new events that we've talked about, but also the age demographic of the people attending. So we know there's work to do with the oldest age group and the youngest age group, but we had fairly balanced representation for everything in between. Also looking at ethnic minorities, and there's further work for us to do with staff representation in that regard, particularly obviously some with the public as well, but particularly with staff. And then obviously gender splits and so on as well. So that's the information we've been looking at, and that's allowed us then to start to put together a plan for the remaining period up to May the 19th on the consultation clauses to make sure we've got the right representation from all areas.
Thanks, Lee. Phil and then Ewan.
Yeah, I just wanted to reiterate my disappointment that we haven't had a tender for the clinical review, and the potential risk to delaying the overall programme, which, as we know, is quite an extended programme already. And we already have concerns about the length of that programme, given the fragility of the services and given all the drivers behind the strategy when we agreed it back in November 2018. So it is concerning to see this delay. And I suppose I'd urge us to support Lee in going back to Welsh Government with those discussions to find a suitable way forward, so we do have an appropriate review our strategy, but in a timely way.
Absolutely. I see nods all around the room, so we can put that in our recommendations and support you wholeheartedly to find a way through this, because we're coming on later in our agenda about the fragility of our services, and this is, this is our way of resolving that. And the longer it goes on, the more people have got to, and staff have got to face the fragility of services in our communities. So yeah, well, thank you, Phil. Ewan.
Thank you, Chair. Apologies, I'm not there in person, but just wanted to make a comment really in terms of the consultation events. And just to note in terms of, it's fantastic to see that it's been a pan-organisation support in terms of staff from across all directorates be there at those events. And of course, we've got the 9 events planned, but I think it is kind of disheartening for some of our staff when they see some of the comments online which are unjust and I think unfair. And I think it should be noted on record that in terms of the promotion, particularly of these 9 consultation events, they were very much done well in advance. I've been to a couple of the consultation events myself in person to go and support the staff, but also to meet members of the public to kind of hear their comments and input. And certainly, I think, as we all know, the one in Carmarthen last week generated a significant volume of unwelcome traffic online, to quote one of the members of the public who I spoke to about the event. And I think we all know that certainly some of the criticism laid by certain members of the public was that there was no advance notice or promotion of the event held in Carmarthen on the 21st of March. But I think it should be noted and put on record that certainly Hywel as an organisation publicised all the 9 events well in advance. It was on ITV News on the 27th of January. It was in the Western Telegraph the 23rd of February, Wales Online on the 24th of February, and also in the Carmarthen Journal that week. And that was well in advance of the first event, obviously, which we all know was the 10th of March in Cardigan, and the events now run up until the 24th of April in St Clair's. So I think it's, from my perspective, I'm sure from many members of the board as well, passing our thanks on to all the cross-directorate staff who are taking their time to actually go and meet members of the public who want to engage in positive dialogue and discussion on this, and not those who sit behind their keyboards.
Thank you, Ewan. Alwena, would you like to comment?
I'd like to just add the thanks as well, in the sense of, yes, it's been great meeting with members of the community during the events themselves, and appreciate that people come at it from a different viewpoint. It's quite an emotive subject, even though we're actually limiting the conversation to 3 pieces of land. People are engaging with us and sharing their views across a whole host of subjects, which is great to see. And just to build, we will and thank Ewan for the comments. We will actually be going out again to promote further events that we are planning following the mid-point review. So there will be, we're currently working on a further 4 events for the period from the end of May, but before the end of the consultation period, and adding another online event too. So thank you very much, and we look forward to seeing more people sharing their views over the coming weeks.
And Alwena, in relation to the topics that the members of the public are raising, not related to the land identification or choice, where are we feeding that into so that we can respond?
We're capturing all the comments as people make them, and the team are collating them. So we're pulling out some of the themes more broadly and capturing them as a team. So we will have a comprehensive note of all of them. And they do vary from individual experience of a particular service, or and they can be good or less favourable, through to very specific concerns around things such as access to the sites going forward. So they're very varied.
Okay, and any concerns would go to the concerns team?
I believe once we collate everything, then yes.
Okay, thank you. Anne?
Thank you very much. During the 6-week consultation, you said there was a younger group and an older age of demographic. I was wondering if there was thinking maybe going into the colleges and universities, because the 18-year-olds today are going to be our 24, 26-year-old users and maybe our staff in the next round.
If I could answer that, yes, we've identified a number of stakeholder groups, and I believe we went to Pembrokeshire College before the start of the consultation, and news spread to Carmarthenshire College that we'd been and that they'd like us to go. So I think they're on our list of people to contact, as well as the school within the zone, to arrange an event with them, fully taking on board the point of engaging with our younger audience. Yes.
Thank you.
And Lee, thank you for coming to the Bain Board Advisory Group. I sent a personal message to all members across how far they would kindly respond, which hopefully will give another group more representation in the response. Any other questions? Thank you so much. I want to thank you yourself, Lee, and Alwena, all the team around the table who've been to the events and participated, and the staff. It's really important that we hear the voice of the public, and I think we are doing our very best to make that happen. I'd also like to ask the board, would they agree that that Lee will make representations on our behalf to Welsh Government to agree a way forward in respect of the clinical strategy review to avoid any further delay in taking forward our programme business case? Yeah, okay. On that basis, you're happy to agree the other recommendations? Yeah. And on that basis, you can have a break. 10 minutes break. Okay. Thank you. Thanks, everybody. Thank you, everybody, and welcome back. If we now go straight to the Improving Patient Experience Report, over to you, Mandy.
Yes, thank you, Chair. Oh, let's make sure I've got one. Thank you. Yes, thank you, Chair. So this month, just to clarify, I am presenting the report that reflects the data for the December 22 and January 23 period. And you'll see that we had within the report surveys sent out to over 20,000 people who had interacted with our services during that period of time. I'd like to say thank you to the 3,097 people that responded, because this feedback is really valuable, and we say this every month, every time we come to board, but actually it really is very, very important that we get it. Of the feedback that we've received, I'm really pleased to see that we've got a 94.8% positivity rating coming back from our population. And whilst that's not 100%, which obviously that's where I would aspire for us to be, it is actually really, really good that we've managed to get over the 90% positivity and maintain that position. So I think that is a testimony to our staff. In the positivity responses that we get, the comments that we receive are about positively about staff attitude, care and treatment, and also some of the communication aspects of their experiences of our services. And I raise that because if you look at the complaints that we receive from the population, you will see there's a degree of similarity around communication, staff attitude and behaviour, which are not as positive as the responses that we get back. So that is something, and if you within the report, you'll see that 23% overall, one of the themes in 23% of the concerns, complaints that we receive does relate to communication. And I know that Lisa will probably want to say something about what we're doing together and across the organisation around the theme of communication, because when you inject people into the system, you will get a degree of natural variation. That doesn't excuse anybody's attitude or poor communication, but it's just the reality that we can expect to see a degree of variation and a degree of perceptions, people's perceptions about what they're seeing, how they're receiving it, and the level of communication that they're receiving as well. So I just want to call that out. I also want to highlight to the board that we've had 6 grade 5 complaints, which are high level. They're significant harm, death even may have occurred, which has been a subject of the complaint. And I need to call that out because I think it's important that we highlight that we don't just look at the positivity, we look at things when they go wrong. So sepsis, surgical management and unsafe hospital discharge are the 3 key themes that have come out of those 6 incidents. And I would like to assure the board and members of the public that these are being reviewed robustly and engaged with patients and their families accordingly. In the report, you'll see this month we've provided a patient story about an acute stroke episode. And I think what's really nice this month is that we've got the perception and the feedback from the patient, who I'm sure won't mind because they have consented, to say that this is an 89-year-old gentleman who experienced an acute stroke. And thanks to the work that we've done over the number of years, actually, around access to thrombectomy, the clot removal service with Bristol, that this individual is now not experiencing long-term symptoms as a consequence of that, and actually are able to get back to their caring responsibilities that they had. We've also got the feedback from the consultant and the difference that it has made, the junior doctor and obviously the staff that were involved in the care of this particular patient. What I would call out is the important message that's within the patient story about think fast, face, arm, speech and time. Really important that we remember that and that our population respond if they feel that somebody is presenting with symptoms of a stroke. You'll see on page 20 of 50 of the report as well that we've also included some sound bites. Those are the verbal feedback that we receive through our system from people who have utilised the services, and you'll see that there's a broad range of services that they are able to comment upon. As I indicated previously, we've also been able to reference the pilot that's been undertaken within primary care in terms of patient feedback. And at the moment, it comes to the end today, tomorrow, and we will then be transitioning across to using the Civica system initially within our health board managed practices. And I hope that I will be able to bring to you the outcome of the pilot, but also the first set of feedback that we have from a primary care perspective. And I think that will add great value. The paediatric survey is also included in there. And whilst the numbers are down, this is linked to staff availability, and the team are actually working on that at the moment. I have Louise, the Assistant Director, who leads on this portfolio, liaising with the volunteer service to look at whether we can do more around how we utilise volunteers. That comes with a challenge because obviously we need to capture feedback consistently, but nevertheless we are looking at alternative ways in which we can capture feedback as well. Mental health and learning disabilities you will be pleased to see within the report in more detail for the first time, and you will also see the range of mechanisms that they have for capturing feedback, again, from people who access their services. By the end of this year, and I mean December of this year, not the financial year, we're looking again to have made transitions and access into the Civica system and the FFT, Friends and Family Test, so that again we'll be able to report even more information. But you will see within the report that we have begun to provide some feedback from the range of services where we have it. I'd also like to just highlight to you as well on page 30, it starts on page 38 of 50 of that report, the work of the Admiral Nursing Service. And again, the feedback that we have received from carers who have experienced the benefits of the Admiral Nursing Service. This makes such a difference to not just the carer, but also the patient themselves. And that is a really important service, and we will continue to monitor and track the impact that it's having on our carers. Page 43, just to call out the arts in health work that's going on and the access to the clip that's promoting the development of the charter. So it's really, really pleasing to see. And I was reminded only yesterday of the link between the Future Generations Act and the work of arts in health in terms of impact on well-being for our population as well as our staff, but also how we're working with the wider community. And I think that if you think that this is a team of one whole-time equivalent, you will see the difference that they have made in the last 12 months and slightly longer than that with the work that they're doing. So I think that that's really, really important. I will pause there and I'm happy to take questions.
Many thanks, Mandy. Questions? Alison?
Thank you, Chair. It's not a question, it's just really, I wanted to say that I was really pleased to see that patient story in there around stroke, because it shows what can be achieved and what the outcomes can be when every pathway goes right, and that's what we're aspiring to. I've made reference to the fact that we've got business case for what we used to call a hyperacute stroke unit, which is now a comprehensive regional stroke centre, going to committee at the end of April. But we're also looking at the rest of the pathway and looking to introduce community rehabilitation, early supported discharge. So I'm very keen and very passionate that we do keep striving to improve the care to stroke patients, because that does show when everything goes right, it can make a massive difference to the individual.
Absolutely. Thank you. Could I ask, do we have thrombectomy in Cardiff as well, or do people have to go to Bristol?
No, people have to go to Bristol.
It used to be
Yeah,
there.
it stopped several years ago.
Okay. Yeah. Okay. Thank you. Is there any plans to reintroduce it?
Not at the moment.
Okay.
I think the long-term hope is that it will be, but they haven't got the staff to sustain that at the moment. But we have got access to Bristol now, which is excellent.
Okay. Just had the privilege of listening at our annual general meeting in Cardiff to a gentleman who'd had one, and the difference it made to his life, almost becoming, returning to normal again. It's phenomenal. Sorry, Della.
Diolch, Chair. I was going to ask a question about paediatrics, as you might have guessed, but Mandy has answered that one. So I've got two really in respect of patients. Patients do often find, well, relatives really find it difficult, and you've mentioned it in the report, of phoning departments and getting an answer. So I'd like to know how we're progressing on that. But also there's mention of parking, and with our sites at high pressure at many different times of the day, what are we doing as a board, or what is happening to actually ease that parking? Because a number of our families and patients find it really difficult to find a parking space. It leads to higher anxiety. They may be late. They might not attend their appointments. So I'm just wondering how we can make that journey, well, that experience better for our patients and families.
If I start, colleagues may well want to come in. I've already nodded to Hugh to say he might want to offer some added context. So in relation to the switchboard and non-answering of calls at ward level, this is something I know Hugh will probably describe the work that's going on around modernisation of the switchboard. We do have an issue, and I know that Hugh and the team get a little bit frustrated with me occasionally because I do a bit of mystery shopping myself around answering of calls, because as you say, Delith, if we do not respond within a couple of rings, people's blood pressure and frustration levels go up automatically. And I think certainly when you have worried relatives who have just heard that somebody's been admitted to hospital, you want fairly swift response to your call. We have been looking at how we make sure that wards have access to reception staff, administrative support, etc. And that is fairly key, because obviously nurses need to be nursing, as do other members of the multidisciplinary team. So making sure that we've got the right response in a timely way is something that we've got as a priority. Before I hand over to Hugh, what I will say, and Lee may want to come in around the parking piece, because we've been doing a piece of work particularly on the Glangwilly site, to create some additional parking just off-site. And hopefully that will, again, alleviate some of the pressures. But certainly from the public engagement event that I've done this week, the P word did come up. So it is something that certainly our population is very concerned about. But Hugh, you may want to say something.
Yeah, diolch, and I can confirm that the Director of Nursing is never frustrating, but the feedback is always welcomed. In terms of the work that we're doing on switchboards, because it is and has been a perennial problem for us, because the switchboards have been managed on their own site. The work that we're now doing is to digitise the switchboard infrastructure, and that allows us then to virtualize that switchboard, so you can call any site, and if there isn't a response on one site, it will automatically get picked up by another site. So it allows us to increase our capacity to respond to calls, and allows us to make sure that we're managing demand and supply then in terms of the calls that come through. But clearly, as those calls then go through into ward spaces, and staff are under immense pressure, and that's going to be an ongoing challenge for us to work through. But this will allow us to better capture data as well on which areas are particularly challenged and respond to that more proactively.
It's actually in the report, and you said we did, and I just wondered what the timelines were, because that's not in the report for the rollout of the system.
I'll have to get back with the detail, but in terms of the virtualization and the digitization, that's already well in train. So by Q1, we should have a response. How we then operationalize that becomes a bit of a challenge for us, but I'll come back with more detail.
Thank you, because that's the most important thing to the public, isn't it? Thank you. Any other questions on the report? May not.
Yeah, a few, sorry, Mandy. First one, it was good to note the public service ombudsman, only half of one report found against us, which I think speaks highly of the way we handle things. Just wondering, do we take the reports which find in our favour and use them to improve our practice? I know we obviously we do it when it finds against us, but so what happens to the reports that find in our favour? We do one at a time.
Do one at a time, yes, because I might forget.
Sorry.
So yes, with the Public Service Ombudsman reports, it's something the Listening and Learning Committee receive on a regular basis. And certainly the Ombudsman's officer that we have within the organisation is really proactive in working with the teams to share the outcomes of reports as well, when things have gone well, as well as when they've not gone so well. And I think fitting in with our philosophy of learning, I'm really driven to make sure that it's learning from the positive as well as when things go wrong. And that is something that, again, Louise and I, the Assistant Director, have been talking about only this week, about how do we step it up now? How do we make sure that we are sharing learning from the various reports, whether that's claims, redress, whether it's the Ombudsman, or indeed any other report that we've got where there is an opportunity for learning. So I think Paul has been an excellent chair of the Listening and Learning Subcommittee, and quite challenging, quite rightly, on how we're making sure we disseminate the learning. But actually, I think it's going to be time again to keep refreshing, and is there more we can do?
Second thing is, one of the things that concerns me is on page 15 and 16, there's a couple of graphs about people being involved in their decisions, on whether they understood what was being done to them. And disappointing to see over 10% in both of those people, people not understanding what was happening to them, or not feeling that they were listened to. That's 1 in 10 patients. I know it's only a sample, but that level is quite concerning. But you go on to page 16, where you've got the example of a patient who didn't feel they were being listened to by a doctor, and then another doctor came in and the experience was transformed. I'm just wondering how we get all of our doctors to listen and talk to people in the same way as what was described as an amazing experience.
Yeah, and I'm sure Phil may want to say something on this. I think only this week, in fact, it sounds as though we've done everything this week, but actually it's an iteration. It's because we're making sure that we're keeping on it all the time. We've been having a conversation about how we make sure that, for example, DNA CPR, so decisions not to resuscitate somebody, how are we making sure that we've got the very best standard and practice, and that that's consistently applied? And the reason I mention that example is because key to that is the conversation, the discussion with the patient, if possible, and with the next of kin. And that, for me, is how we go about thinking about the shared decision making. And I was talking to one of the heads of nursing only on Monday about another conversation that I've been having, to really go back and say, okay, so what is it that our sisters, our band sixes, our staff nurses need to help them have better conversations with patients and families? Because we think we might be giving them the tools, and Lisa, I'm sure, will want to mention the Making the Difference programme and everything else. But actually, are they having the impact that we need? What is it? There must be a nugget that we can utilise. So that's something, but I'm sure Phil will want to respond specifically about medics.
Yeah, thanks for the question. And it's clearly a really important aspect of anyone's care, the kind of information that you get from your clinician and the interaction. And it's constant work in progress. I mean, for doctors, it's a really key part of the training from when they're students all the way through. And I think all the way through to the end of people's careers, it's a constant need to reflect on how good your communication is with patients, and also how good your listening is as well. So it's not just that's part of the communication. So I suppose what this shows is just how important feedback is, and how important it is in the moment, and that it's specific and goes back to the individual doctors. And that's something that we continuously work on with our doctors. Part of appraisal is there for doctors to, I know it's for nurses and therapists as well, to reflect on things that have gone well, but also things that haven't gone quite so well. And so these are just the sort of things that need to go back to individual doctors, and we do that on a continuously.
Next one's about the Admin Nursing Service, which you already mentioned. I'm just wondering how big that service is, and how available it is across the whole of the health board.
Yeah, so I haven't got the exact details, but I can certainly get information back to you. But it's I'm really proud of that service. I think it's one that
Sounds great.
Yeah, we'd want to hold on to. So we'll get you some further detail. I'll give you perhaps a briefing.
Okay, great.
Thank you. Chantel, then Mansell.
Thank you, Chair. Just a quick question around lessons learned, said, and we did, and in particular in terms of mental capacity, because I do know that we deliver a lot of sessions, training sessions in relation to mental capacity and deprivation of liberty safeguards. So I was a little bit surprised to see that, and I was just wondering whether there is a bit of a gap between how they've been taught and how they're actually implementing it at ward level, and whether it might be a good idea for us to introduce like an memoir so that they can use that on a regular basis in order to be able to implement the various aspects of the mental capacity legislation, which would capture the power of attorney, decisions and all those kind of things as part and parcel of that. So whether we've given that some consideration. So that's one of the questions. The other one was in relation to patient being discharged and not having clean clothes. Is that because the discharge is happening very quick, or is that I don't quite understand how we could be sending patients with unclean clothes.
Yeah, so if I take the second, well, the first point about the Mental Capacity Act, thank you. I will pick that up with Madeline and the team to see what more we can do to try and make it as easy as possible. As I keep saying to people, nurses in particular are expected to remember 1,000 things a minute, and they can't remember everything and be perfect on everything all of the time. So anything that we can do to make it easier for them to recall things, and just almost, I don't like checklists, but almost have a mental checklist available to them is certainly going to be a positive. So I'll pick that up with Madeline, our lead on it. In terms of the clothing issue, as you'll appreciate, the rapidity with which we are having to move people through our services is unprecedented. And as we've gone along, you know, in my career, you never discharged a patient out of hours. You never discharged them on weekend. That is now the norm. And sadly, sometimes people do not have all of the belongings that they need with them at that point in time. Sometimes it's because the staff haven't been able to acquire clean clothing from relatives or next of kin. Perhaps they hadn't anticipated the discharge being quite as quick as it was going to be. The most important thing is to get that person home. For me, it's the way in which we do it in as planned a way as we possibly can, and that includes clothing, making sure that the house is warm, that there's food in the fridge or whatever, so that they're going into a suitable environment. And if we haven't got clothing for them, that we protect their dignity as best that we can. So that is, and again, I can look at whether there are additional other alternative gowns that we could be using to further promote dignity in the absence of clothing. But I think it'll go back to the rapidity with which we're having to undertake this action. Doesn't mean to say it's right, but I will go back and look.
Thank you. Ansel.
Thank you, Chair. I just want to go back actually to the parking. It's one that we get told about all the time when we speak to the public. Now, I know that a lot of work has been going on, especially on the Glangwilly side, for extra parking spaces. I'm speaking to hospital management recently. They said it would open on around about April the 3rd, something like that. My question is really, is it going to be managed? This car park is a little bit away from the hospital itself. Is it going to be for staff, or is it are patients going to be then closer to the hospital for the difficulty in getting in and out of cars? The other thing is that the council are withdrawing the park and ride from coming from the Pembrokeshire area, so people are more reliant on their cars, and it's a big issue for us. So I just wanted to know what was happening on that score.
Thank you.
Yeah, thanks for the question, Mansell. The intention is that we would encourage our staff to park in that additional area, freeing up the spaces on site for patients and visitors, because we're acutely aware of the challenges that they're seeing, particularly between a Tuesday afternoon and Thursday at the moment, when we're probably our busiest in terms of the number of sessions and clinics running and demand for spare parking is at its peak.
Okay, it's just that, thank you for that answer. It's just that it would be useful to know if it was being managed. So that rather than staff saying that they could park out there, because on experience, if staff can park near the hospital, they will do. And we understand that. There's a balance to be struck, isn't there? But from the patient's perspective, it is very, very important.
Yeah, I'll come back to you outside that in terms of the specifics around the management of it.
Thank you.
Okay, maybe you could copy us in because that's going to be big and response from the public. Yeah, thank you. Right, we are running over time, but I do have a few questions on the report, so and I'll be quick. We talk about the 6th grade 5 and sepsis as one of them. I don't know if there's just one sepsis or more, and is it site specific? It's great to see that almost 70% of complaints are responded to within 30 days. I remember it used to be around 30%, massive improvement. So can you pass on the thanks to the team? And you say the Ombudsman's going to move to a system of upheld or not upheld. No, we are, and partly we're going to get rid of the partly. Is the Ombudsman going to do the same? Yeah, okay.
That's my understanding.
Okay, that's great. And A&E, you say on page 11 of 50, the issues about A&E. I understand when I actually did a couple of hours on shift in scrubs with the cleaners in A&E in Withybush, and I learned so much. And one of the things they said was about the Red Cross. So we're going to reintroduce the Red Cross in A&E in Withybush.
I think Andrew may want to do an initial response to that because we have got a mixed picture across the 4 sites.
Okay, and then my last one, I think it's Lisa's, talking about the ways that we're doing that communication can improve. Phil's talked about the doctors, and I think they're probably doing a piece of work. Lisa, and that's it. Thank you.
Okay, thank you. So I think if Andrew was able to pick up the Red Cross question, what was your first one? Sorry,
the first one was about site-specific for sepsis.
So just to reassure on sepsis, there is currently a national piece of work going on around sepsis. So whilst I'll answer your question, it will be indirect. So we have already collated all the evidence that we have and submitted it, and that's now been paused on a national basis through HIW, but there's another piece of work going on. I've also asked the new head of what was recess, but now is the patient deterioration. And I've asked him to review where we are around compliance against sepsis bundles, not just within our A&E departments, but actually across the rest of the organisation as well. We did make significant improvement, and then COVID came along. Things aren't quite back where I'd like them to be, so we're doing some further work on that, particularly in relation to access to the micro guides, so that medics and prescribers more generally can have access to the right information in a timely way. Sepsis is, we actually perform overall, when I looked at the data a couple of weeks ago, we're performing reasonably well, but reasonably well at 90-something% still means that there is a percentage of patients that are not having the right response in the right time. So that's something we are already picking up on.
Okay, thank you.
So on the Red Cross issue, as Mandy's articulated, there's a bit of a difference in approach between the different sites, and the issue and discussion review of those contracts takes place on a regular and annual basis, both by the sites, the county team, and the and with the Red Cross too. That's led to different positions. So I know at the moment, for example, Carmarthenshire had 2 or 3 different services they commissioned through the Red Cross. They're in the process of a discussion and negotiation around those 3 contracts and working through how they align that better so there's no duplication, and they perhaps manage to deliver more impact and benefit and support within the resource that and within that contract available. Withybush, I seem to remember, withdrew the Red Cross service because they had the flows, and they felt that the flows, those are the family liaison officers, the roles that they were playing in the wider sense within the department was more than providing what they were getting from the Red Cross contracts. They said they would rather have kept those as part of their substantive workforce and within the resource allocation they had. I can go back though and just double check whether there's any further conversations this year or going into next year around Red Cross in Pembrokeshire in particular, but I'm not aware of any.
Okay, thanks, Andrew. It was just the feedback from staff that they appreciated the impact of them. And last, I forgot to ask, page 17, maternity passport. What's the date that will be introduced?
My understanding is they've already got it, but I will just double check to make sure that it's consistent across the counties.
Thank you. Can you pass on our thanks to the team? You know, this report, it can always improve, but it is a growing report, and it brings so much richness to our board about the impact of our services, both good and bad. And I didn't bring Lisa in about the comms. You're not getting away with it, Lisa. I know. Give yourself away there. Over to you, Lisa.
Okay, so it links in with the action that was at the very beginning of the board around bringing a paper to the People Committee. So one of the other actions that the team are doing is that there is a meeting with the Deputy Medical Director and Postgraduate Education so that we can triangulate the report, the training programmes, medical attendance at making a difference, but also how we can introduce communication into some of the generic education programmes that are taking place with our medical workforce as well. So it is in train and it will be part of the June report.
Okay, many thanks. Well, thank you.
Chair, may I just mention that I know that there was some query about what our next patient story would be, and it will be about palliative care.
Great.
So the story is currently being captured as we're here today. So that's the.
Thank you. And it will come to board with staff.
Yeah. It'll depend upon what they agree to do.
Okay.
So we will bring it here to the board.
Okay, we will leave it in your capable hands. Thank you. If we can now go on to the next item on the agenda, which is the quality improvement and quality management system. That's over to you, Mandy.
I will be as quick as I possibly can, but I hope you'll allow me to feel extremely proud about where we've gotten to as an organisation when it comes to quality improvement. So I think what's important to say is that the paper attempts to bring together and demonstrate that quality improvement isn't something that just sits with me or within my directorate or with Phil and Alison as clinical leads, but actually quality, and certainly through the quality management system, is something that affects everybody's portfolio and will become extremely important when we're looking, as we've discussed earlier in the board meeting, around the plan and the planning process. So what I would call out from the report is that since 2019, when we set up EQUIP, we've had over 500 members of staff that have gone through and experienced the quality improvement programme. That's capacity building in real time. So when I first arrived, I had 125 lone individuals across the entirety of the organisation. So COVID unfortunately slowed us down. We could only operate on a half-equipped programme, but we've stepped that back up again, and the feedback from staff continues to be captured and modify the programme as we go forward. I think what is important to say is that as well as our people that have developed their improvement capacity, we also have 55 improvement coaches, and those are integral to enabling us to continue to develop and support improvement. So whilst we've got people going through a formal programme and they don't just walk away, I'm really pleased to say, and say, well, I've done the programme now, I've ticked a box. They're actually making a real difference, and they're picking up programmes that they're then confident not to have to take through a programme because they've got the skill set. And they are taking, importantly, back the skills and knowledge and experience they've had from the programme back to the wider workforce. All the programmes are multidisciplinary, and in fact, I'm really pleased to say that we've also had some patient participation and also some local authority participation as well. So that's really, really pleasing to see. I'll stop gloating now. The other thing to say is that obviously we have connected in with the National Safe Care Collaborative Programme as well, and we were really pleased to have been asked to present the work that we've been doing on how we're joining the dots and how we're making improvement connect in with the 6 strategic objectives that we have, the 6 policy goals that we have from TUEC, the Transforming Urgent and Emergency Care, and how actually we don't just see it as something that sits on the side, it's integrated into how we do our business. And importantly, particularly strategic objective 1, where we're putting people at the heart of everything we do. And that is writ large, I suppose, through both the EQUIP programme, but also the other work that we're doing to drive improvement. You'll see there's a little bit of mention in the report about the waiting list support programme and the impact and the pace now at which it's beginning to work and be able to make a difference, not just to our patients, but actually to operational services in the efficiency and effectiveness with which they're able to deliver services. And of course, attached to the report is the updated quality improvement strategic framework. Again, a little delayed because of COVID, but it's here. And again, it's taking us forward in terms of how we want to go about doing our business and captures the essence of where we need to be around the Quality and Engagement Act. And then the quality management system. So again, this has been a bit of a long time coming. It's been like birthing probably 2 elephants, but it's because it has felt very long. It's been to Quality Committee, I think, twice now in its development, and thanks to Anna and her experience, we've had several iterations of it, but it's also modelled on some of the best QMS frameworks across the UK, and we look elsewhere as well. So the way we go about doing our business, thinking about planning, how we're going to build quality into our planning systems, our assurance systems, how we use our data, looking at how we're using our improving together sessions with the directorates and the wider organisation to make sure that quality is embedded throughout everything that we do. And apart from that, I think I'll stop and I'm happy to take any questions.
Thank you, Mandy. You know, your passion showed, and we're all with you on this. Any questions? I don't know if Anna, you want to add anything as chair of quality?
Well, I mean, Mandy's covered it really thoroughly, but I think it is a moment of pride for a number of us who've been involved in this journey from the beginning to see it come to this stage. And we've of course got lots more to do, but fantastic work from lots of people and a great reception, I think, in the organisation that has been building momentum over a number of years. So congratulations to Mandy and many others.
Thank you. Right, on behalf of the board, can you pass on that congratulations, Mandy, and to you personally as well? It's so heartwarming to see the people and be exposed to some of this process. And is the board happy to approve the recommendation, which includes this quality improvement strategic framework and the quality management strategic framework, which I'm sure not only draws on the best, but is the best. You know, thank you. There you go. Okay, the next item on the agenda is the financial report. Hugh, that's you.
Thank you. In terms of our outlook for this year, we are still heading towards that £59 million deficit, assuming that at this stage it's a tight landing, would be fair to say, and that 59 million we're working through over the next week or so in terms of now the actual outturn position. Our cash position is on track to deliver towards the end of the year. As you'd be aware, we're not allowed to clearly go overdrawn, so we're working through the implications of that today and tomorrow. Just in terms of a few updates on where we'll end up at the year end and the balance sheet position for the year end, clearly the pay negotiations and the impact of the pay negotiations will be accounted for this year, recognising that some of the expenditure will be paid out to staff next year in cash terms. So we're working through implications of that for the position, but I don't foresee any risks. And of course, recognising that a big shift from last year to this year is annual leave. Where we had a very significant accrual for annual leave carried forward at the start of the year. That accrual will have shrunk quite significantly towards the end of the year. There are some areas where there is remaining some carry forward. I'd have liked to have a more robust process in place, but we are moving to making sure that everyone is capturing their annual leave through ESR, but not quite there with sufficient assurance at this stage. So we'll end up with a sampling basis to provide assurance for our outturn position. Audit Wales, Chair of Audit Committee alluded to the position with Audit Wales, and it is disappointing that we'll end up with a delay in our audit and anticipate that being reported to the end of at the end of July. That does place some very obvious operational pressures on our teams who are having to respond to audit queries, but we did have a very productive session with the audit team from Audit Wales last Friday, to work through the risks and the implications for the year end. There is a significant change in audit audit regulations. So ISA 315 is now the audit regulation they work within, and that is very much more risk-based approach for audit and targeting at areas of key judgment, targeting at areas of worries around management override and the risks that are quite inherent within that space. I am also apparently wild boar-like looking for embedded leases. That is that is an area of quite significant technical accounting intervention and a new complexity for us going into this year's audit, and of course adds to the risk of the position. So that's broadly where we are on the year-end position and the outturn. There are a number of areas of approval that are noted in the report as well. The first to reference is hybrid print post. I think this is the first time I've ever taken stamps to board for approval. But and the reason for the significance of the contract is that it does include all of our postage costs. So it does require Welsh Government approval. So after board approval, we'll put it through to Welsh Government. But the net cost of the contract itself is quite nominal, other than the postage cost. So there's an £80,000 capital allocation needed and £49,000 each year. But there's a very clear route to delivering savings from that. So I didn't want to delay bringing that to board, given the opportunity for us to progress. The second item is consultancy, and this is Arcus, who have been working across Wales on providing advice and support on the best way to provide business partnering support to the organisation. And as part of our TI conversations, this became part of the support that we would be seeking. We are in discussion with colleagues in Welsh Government around funding that, and I very much hope that that funding will be forthcoming as we go into next year, but keen to progress that as quickly as we can with board's approval. The third item is mental health tender contracts, and this has been a phenomenal piece of work from the procurement team and mental health colleagues within the Mental Health and LD Directorate. A very big and complex piece of work that means that we have moved ourselves from a historic position where we had very reliant on single tender waivers actually in this space to now a place where we will have proper governed programmes and contracts in place. It has been a challenging process. There are some errors, unfortunately, on page 6. I just want to provide assurance to the board that every title should have 90-10 as a technical to commercial split on the community wellbeing section, whereas at Pembrokeshire and Ceredigion are noted that at 80-20. The net result is the same, doesn't change. So please forgive me for that error. And there's a transposition error in the columns as well. We'll correct that and reissue that item. And then the last element is an extension of our Lightfoot contract. Board will be aware that I bought the contract for approval probably December, I think, November, December of 21. And I was planning on exiting that contract and having an exit strategy by the summer of last year. And that didn't happen, and it's been carried on at no cost for us to the end of this year. The scope and the use of that contract has changed. And it's now being seen as quite a fundamental part of delivering transforming urgent emergency care. It's great to see it being utilised, but it has meant that given the change in scope, we do need to extend that by another 6 months while we work through what are arrangements to provide data science, provide intelligence to the organisation differently will be in the future. So that is an ongoing extension. But at this stage, I would only want a 6-month extension for that and plan to have an exit strategy in good time for that duration. Chair, that's it. There are a number of recommendations noted.
Thank you, Hugh. Any questions? Paul and Judith. Sorry, Judith.
Oh, okay, thank you. Yeah, it's not so much a question really, but I just think I need to reference all the detail in Appendix 2. And I think it's such a huge exercise. I think I do want to just note all the work the team has done. And the procurement support they've had has been really helpful because this is not a natural area shall I say, and some of those arrangements, I don't know, I'll call them contracts, have been going for a number of years. Not that they've been a concern, but I think there has been recognition that there hasn't been equity across all of the health board because of the nature of the way they've grown up. So this hasn't been without its difficulties. There have been some providers who have not been happy with this approach, and the teams have had to manage that dynamic as well as do this in a very professional way. And if you just look at the range of those services, which are at the top of Appendix 2, it's huge and it's so significant. So I just wanted to note that and to thank the teams within the mental health and LD for all the work they've done with the support of procurement.
Thank you, Judy. Oh,
Yeah, I had a question on the mental health tenders, in fact. Looking at the tables and page 460 of the bundle, page 4 of the report, lot 1, we are awarding a contract to providers 6 and 7. 7 in particular, where the total score is 24.9 out of 100. Provider 6 is 41.5 out of 100. Are we assured that that's an appropriate level of scoring to award a contract?
Chair, I'll happily pick up a conversation offline and provide more assurance on that. I think that's probably the easiest way to address it, because we get into individual specifics, specific providers, which at this stage will be commercially in confidence. So if I may respond.
Sure.
okay, thank you. And you can continue to raise if you have concerns.
So just be aware of that. I think that seems like a low score to be awarding a contract. And what's the threshold for saying you can't win a contract if it's 24.9 is sufficient?
Perhaps we could take it through it in committee.
We will do.
Yeah,
absolutely.
Yeah, that would be great. Mansell.
Just one on the hybrid print and post, which obviously is quite close to a CHC's heart, really, in relation to ensuring that those who can't receive digital will receive the letter, which is it's said in the appendix. But it's something that we would have liked to have worked with you on. And I think it's important that Clyce now scrutinise that, because we've worked hard with different teams across the health board in getting letters out and communications, which we've spoken a lot about, especially with waiting lists. So I don't want to put any work on my chief officer, but I think it's important that we scrutinise this to make sure that it works properly.
Just to respond, we've thank you for that and very well made point. Our approach to hybrid print and post is going against the grain where this has been implemented elsewhere. We are going for an opt-in basis, not an opt-out basis. So people who have to opt in to receive it digitally, whereas generally you have to opt out of getting it digitally. So we are assuming that people will still want to get this by post, and there will be an option of opting in fully digitally or opting in to having it both digitally and in paper. And we're working with the PSPP team as well to make sure that this integrates with the NHS app. But we're not at a stage yet where we are operationalising this. So certainly the timing is right for us to make sure that we've got the engagement and support to implement it properly.
Thank you. That's very reassuring. Thank you.
Thank you. Could I just pick up the Lightfoot extension as well? My most recent visits through Glangwili with Rhian and the Minister and the Under Secretary of State for Wales, the real-time data that Lightfoot system has helped us to access is the lifeblood of the transformation and the lifeblood of service change effectively. And I just wanted assurance that the next provider iteration, in-house or out-house, will bring staff who use the current system to ensure that it's user-friendly and it provides the similar intelligence in the same time as they get now. So we're not taking a step backwards.
Chair, absolutely. I think as we approach any digital or data intervention now, we're very much thinking people, process, technology. Technology comes last, people come first. Making sure that any design is user-centric is absolutely critical to the approach. So anything that we do bring in place instead of Lightfoot or a continuation of Lightfoot, if that's the conclusion of any review that we do, there it needs to be absolutely user-centred.
Okay, many thanks. So the board happy to approve the 4 requests as specified in the recommendation? Thank you very much. The next item on the agenda is the Integrated Performance Assurance Report. Over to you, Hugh.
Cadeirydd. So IPARS there, and the format is very consistent with what you will have seen before. Just a few things to highlight. Clearly on planned care, we're on target to achieve the 52-week outpatient and 104-week treatment trajectories by 31st of March. Urgent emergency care, clearly a very challenging position. And while we're not seeing improving variation, there were some positive signs that we were seeing in the last month, but challenges remain. Very conscious on neurodevelopmental services. Only 15% of patients on the ASD pathway were seen within the 26-week period requirement. Within cancer, just worth picking up that there has been a small reduction in the backlog, 73 patients, but we still not recovered yet to the pre-December figure, and there remain challenges in performance on C. diff improvement as well. Very positively, and refers back to the work that we talked about earlier on workforce stabilisation. Workforce recruitment has exceeded the ambition, and that's really good to see, and hope to see the impact of that feeding through as part of next year's plan. And just to note as well for board, we have changed the way in which we're capturing ready-to-leave patients. So if board members compare this report back with a previous report, you'll see a big increase in the numbers, but it's because the calculation methodology is more robust now. And we, at the end of last month, 295 patients were noted as being in that category.
Thank you, Hugh. And I also, just for noting, the detail of this report has been considered by the SDOC committee before it's come here. Can I just say, I just think the report is really clearly presented. It really, really is. It's an exemplar. I'm going to open it for questions. Andrew.
Just a few comments, if I may, Chair, because I'm conscious that there's a number of areas there that are certainly not delivering the levels of performance we'd wish to see as a board, and I'm conscious as well that a number of those are areas for our enhanced monitoring escalation with Welsh Government. So I thought it would just be helpful to cover a couple of those off in this conversation, and I think it probably references some of the content of the operational update as well, so it's sort of combining two issues there. So I think, as you says, plan care, we're making good progress, and we're on track to deliver our trajectories that we set at the start of the year, and we anticipate with the plan that we've agreed earlier on, we'll continue to see that improvement through to June, certainly in terms of the plan, and we'll actually hit the ministerial outpatient milestone by the end of June with the plan we've got. So that would be a big milestone for us in terms of our plan care programme delivery. In terms of cancer, as you noted, we made some small progress in February in terms of our cancer backlog reduction, which is where our focus has been. I think in doing that, I have to acknowledge that whilst cancer performance would be worse whilst you're reducing the backlog, our performance of 38% was still lower than we would have anticipated it being in the month of February. The position is still being validated and worked through at the moment for March, but I'm, as of yesterday, so only 2 days to go, so it shouldn't change too much. We were looking at we will have recovered our performance against a single cancer pathway to around 51%. And I think in terms of our backlog reduction, we should be only now a month behind our original trajectory, having been focused on recovering the blip we saw at the end of last year. And our expectation would be the backlog, and we recover the backlog to a more sustainable level performance-wise through Q1 of the next financial year. So I think that's important to note as well. Urgent emergency care continues to be a significant challenge. I think we have seen in February improvement for the third successive month against a number of the key measures and a number of the key metrics that Welsh Government are monitoring us against from an escalation perspective. We're very clear that we need to see another step change in improvement in our performance and then achieve a level of consistency against that. And I think that will start to put us in a better space in the escalation conversation with Welsh Government, who generally across all of our areas of performance, we're quite reasonably positive about the progress we are making and the evidence of the progress we're making, even if we're not quite where they would like us to be yet. March has been a particularly difficult month again in terms of urgent emergency care. We've seen challenges again around some of our infection prevention control pressures. So in the context of the number of COVID patients in hospital at the beginning of March, we had over 60 again. So and we had competing issues around norovirus as well. So there were issues in early March that were not dissimilar to, although probably about 50 to 60% of the scale were not dissimilar to the pressures we were seeing at the end of December and early January in terms of flow. Of course, through March, we had also maintained our elective activity and capacity as well, whereas in the new year we'd cancelled that. So there were some challenges there, just to and there seemed to be some fragility in our delivery and our resilience when we get those numbers through. So I think one of the things I've talked to the team about is how do we really plan to be more resilient, to manage those, particularly the respiratory virus challenge, in a different way, so it doesn't have such a dramatic impact on our capacity and flow. And whilst I suppose all these things, whilst we're talking about improvement and the position feeling better, I still am really clear that, and it comes over in to a large degree in the sort of the side of the conversation and the engagement events we're doing at the moment, that very conscious that the experience people are still receiving is still not, and the access is still not anywhere near where we want it to be, and we've still got much more to do to get back to where we were 2 or 3 years ago before COVID, and there's a real commitment from the team to want to deliver that. Finally, just on mental health, because I think the neurodevelopmental performance is a real concern for me. Having reflected on that with the directorate, I've had a conversation with Welsh Government around some support from them through our escalated status to get some expert help in externally to come and help review the pathways and review the service, to help us make sure we're putting in place not just a sticking pass that reduces the waiting times numbers, but a service that properly meets the needs and needs of the population. They were very interested in that because they've got their new neurodiversity policy published, and they see it as an opportunity to see how an organisation can translate that into an operationally delivered service as well. So there's a conversation we're exploring there to get some of that expert help in to support that work, which I think will help give us more assurance as a board that the actions we're taking will properly and in a sustainable way over time address those new developmental access challenges that we've got at the moment.
Thanks, Andrew. It's really comprehensive. Alison.
Thanks, Chair. Can I just add to that, just the fragility around things like the industrial action? And I can give an update about the industrial action in the next paper. But you'll have noticed on page 12 of the report that it reports an increase in physio weights. There's a word missing. It should be 761 patients, not an increase of 761 in the month. But actually, that was largely due to that 1 day of industrial action that was planned that was stood down at the very last minute. We lost 570 appointments, managed to reappoint some, but unfortunately not all. But again, equally, 1 day's action can take out 600 outpatient appointments as well. So I'm hoping I've got some positive news in the next paper, but it's just to point out that fragility really, that anything like that can have a big impact on our trajectory and our plan.
Yeah, thanks, Alison. Audrey.
Yeah, as you say, very clear report. Just one question regarding workforce. How do we compare in staff sickness to other boards? We're 6.58%. Full-time equivalents. I know it was 5.85 last month, but how do we compare in that respect?
Out of all of the large health boards in Wales, we are the lowest sickness absence rates.
Okay, thank you.
In fact, there's other statistics there as well, Lisa, isn't it, that you shared with me recently? I don't know what you'd like to share with the board.
In terms of some of the general metrics for workforce and OD, we are one of the highest performers in PADR. So even though we've talked about, is it good enough? Actually, compared to the rest of Wales, we are performing well. Same with core skills training, so our mandatory training, and we also have the lowest turnover in Wales. So all of the key workforce metrics compare very well when we look at other large health boards in Wales.
So that reflects well for Hywel Dda, and I have to say it's kind of and I just wanted to ask the question because having that benchmark compared to others, and I don't think we're selling ourselves I think we should sell ourselves more in some respects. People are happy to work in Hywel Dda, which is good.
Could I make a suggestion that I share the workforce metrics report that goes to the people committee, because there's lots in there that does show how we compare to other organisations.
Thank you.
Good. Thank you. Anna and then Delith.
Thank you, Chair. And thanks, Andrew, for giving us that overview. I think that's really helpful. I think, we would all share significant concern around the lack of progress around neurodevelopmental services, which you have called out, and very much welcome a more strategic look at what we might do differently, because it seems that after an awful lot of trying, we're really not gaining any traction in terms of any improvement there. If that looks as if it is going to be a position that we are going to struggle to get out of anytime soon, I wonder if we are asking ourselves whether we're doing absolutely the maximum possible to support families and children, young people, siblings and families to cope with the consequences of undiagnosed, unmanaged neurodevelopmental needs, given just how significant that is for family life, for education, for working life for parents, etc., etc.
I think, thanks for the question. I think from a directorate perspective, there are a number of actions they're taking to put in place support for people that are on waiting list, waiting to access our mental health services. And we've got a range of counselling type support and advice support that people can go to whilst they're waiting. I think there is a real challenge in your question though about whether, given the scale of the performance issue, whether we're doing enough in that space, and that's something I want to take away and have a look at, because I think that whilst we're trying to reduce those waiting times, we need to make, as you say, we need to make sure we are doing everything we possibly can. I should have added that obviously we've talked here before around the outsourcing contract and arrangement, and whilst we would like that to provide more capacity than it's been able to provide in terms of the response, that has now commenced. So we are now starting to see that capacity help manage the waiting list and treat our, in order of priority, those children, people waiting.
Thank you. Delhi.
Diolch, Chair. Anna's asked one of the questions I was going to ask, as you might have guessed. The question for me really is about our community-acquired infection and whether or not we are looking at this strategically and preventatively. And it does mention the use of antimicrobials, and has that increased? And are we working with our community physicians and our primary care colleagues to really look at this issue?
So if I may respond. The board and others will be aware that we're in enhanced monitoring around our C. difficile in particular, but also we're looking not just at one particular organism, but the whole of the organisms that we're dealing with. So our whole healthcare associated infection burden, for want of a better expression. Within that, the one thing I would say is that our primary care colleagues and primary care pharmacy support is excellent. And in fact, they're exceeding their performance where we would expect to see. So that's a real positive for us. Nevertheless, the burden of infection remains in our community environment. Now, that's fact, and it reflects the age and demographic of our population. Some of the work that we're doing within our very detailed healthcare associated infection plan is to liaise with colleagues in primary care, public health, to look at how we tackle this strategically in a different way, perhaps from the way we've been doing it before. So antibiotic usage in community, we're doing well. There's more work we can do, but we are doing well. Secondary care, we've instigated some mandatory expectation around audit of antibiotic usage, and that's for any junior doctor that comes into the organisation. We've reinforced the microguide, as I referenced earlier, around selecting antibiotic of choice. We're doing Start Smart and Focus. So once people are in hospital, we've got a range of things to try and make sure that the timely review of antibiotic prescribing is actually taking place. So all in all, we are beginning to get significant traction. And in addition to that, to make sure that we stay on target, I'm doing regular quality panels with each of the directorates to have a personal conversation about what more they could be doing. Interestingly, it has led to quite a lot of traction and a personal letter to the Minister up by one colleague, which, whilst it was interesting that they chose to take that route, I think what it showed was their ambition to actually become the best rather than the worst in Wales. And I think that's a real positive, and that's the ambition that now we're driving across the whole of the organisation.
Thank you, Mandy. Thank you. Jo.
I was just going to add to
Jo, can you move your microphone?
Apologies. Sorry, I'll get right next time, honestly. Just to add to what Mandy has just said, we're really, really fortunate in Hywel Dda to have quite a motivated microbiology team who over the last few years have worked with our GPs who are the highest prescribers, going out to GP surgeries and doing that education with them, which has been massively well received. We've also got a process of narrative reporting, which means that when people get their results, when our GPs or our secondary care colleagues see an organism, they don't just get, this is what the organism is, they also get advice from our microbiology colleagues saying, actually, if the patient isn't symptomatic, you don't need to do anything here, you don't need to prescribe. So that's something that's been driven from Hywel Dda. It's being rolled out, I think, across Wales, but that system, I think, has put us in quite good stead in terms of appropriate prescribing.
Thank you. Thank you. Andrew, could I just ask a couple of questions? On page 7 of 18, we talk about the rapid diagnosis clinic for cancer that was introduced at Llanelli. What's the uptake been like, and what are our plans to roll them out if it is successful and if we have staffing?
The uptake has been really, really good, and the feedback has been really positive. I think one of the, and when we set that up, it was always our intention to review progress and look at how we perhaps roll that out across the wider health board area and geography. I think one of the challenges we've got at the moment is there is a view from the demand that needs to go through that we might not need additional clinic capacity to meet the need and demand that we've got. And whilst we might have expected more feedback from those that have attended in terms of travelling and distances, that's not been coming through. People have been very supportive of the access to having access to the service and the support it's given. We'll continue to look at that though, and it is a live conversation about whether we rotate the venue for the clinics, for example, and identify location space. There's a couple of factors tied up within that space being one, but it's in terms of the delivery of the service, it's not coming back through the formal feedback into the service that's a particular issue, but it's certainly something that's on our sort of radar to continue to look at and consider.
Thank you, that's assuring. And you say about the SDEC model may need to change based on the analysis. Do we have any sort of intelligence from that analysis how it should be changing?
Yeah, so in terms of SDEC, there's two things happening at the moment. One is Welsh Government have asked for an update in terms of our plan for SDEC services for the next year. It's part of our plan. There was a follow-up to our plan, and we've just undertaken an internal peer review of our SDEC services across the health board. Karen Brown, our lead clinician, has picked that review up internally, and the teams have been considering the report and data and recommendations from that over the last couple of weeks. I think, as you'll appreciate, and as we've talked about before, one of our challenges as our health board, particularly in the delivery of emergency care, is the level of duplication that's necessary because of the number of sites and front doors we've got that are required at the moment because of the geographical layout and configuration of our acute sites, which is obviously what our strategy and long-term plan is looking to address. So inevitably that throws us a challenge in terms of how we deliver services like SDEC that need to be associated with front door services. One of the considerations that's come out of the review so far is that there is potentially a lack of resilience from having two services operating within Carmarthenshire, and that there would be benefits from merging those two services into a single location in terms of coverage through the week and provision. So we've seen particular challenges at Prince Philip, for example, and been able to staff that 5 days a week. And there's a consideration being given at the moment. There's a meeting today actually going on between the clinical triumvirates looking at what the right model would be. With the model that's going into the wider Carmarthenshire system, which will see a central point of contact for referrals from GPs through the intermediate care hub in Eastgate, that would obviously facilitate an approach whereby we didn't necessarily need an SDEC on each acute site. We could have a single one that we've directed patients into. So that's where we're at. There's nothing that's still being worked through, but the indications are we probably don't need 4 and could get better use of our resource by reducing to 3.
Yeah, thank you. And my final question is about the Home First and the Carmarthenshire model. And you say in the report that analysis of the other 2 counties will be taking place to see when they can be rolled out. I just wondered, do we have a timeline as well? Some of the components, I know there are things in the other 2 counties, but some of the good things in Home First will be rolled out in the other 2 counties.
I think it's a good question, because I think we've had a bit of a debate with the counties, haven't we, Jill, around the Home First being an approach as opposed to a service in itself. And I think when you talk to the counties, when you look at the components of Home First and what it consists of, each county will have components of that in place already. So they would already say they're operating a Home First approach. I think the challenge we've got through the work we're doing, and it goes back to the further faster piece and the conversation across the region, is where we would like to get to is that there's a far more consistent provision of those services to meet local needs. Even if the way they're delivered might look slightly differently, you could look into each of the county systems and see similar responses to similar needs. So that's obviously part of the discussion at the moment. I know the challenge, certainly from Carmarthenshire and Pembrokeshire with the conversation with Steve, is that we want to move that forward quickly over Q1, because obviously where we want to get to is we've got this in place for next winter. So I would envisage those conversations picking up and getting to somewhere over the Q1 next year, because we'll need to be in that place to implement a response for the autumn. I know Jill probably want to come in on that as well.
Yes, I think it's a really interesting question, and this discussion about an approach and what services are available locally. And I do think that probably what we might see coming out of Welsh Government, we did have a visit from the Director General to look at the Carmarthenshire service a couple of weeks ago, is that you do need a core set of elements to bring together. So even if there may be certain variations within each county around those components, you need all the parts to make that service work. But the other really important thing, which was very evident during the Carmarthenshire visit when all of the teams were present, is that it goes back to the point that we were talking about earlier on in the board. You also need a willingness to work differently. And I think you can have all of those component parts and all of the right teams in place, but the system may still fail because you haven't got that innovation, that enthusiasm and that passion for working differently to deliver services in a different way that was very, very evident from the teams that were part of that discussion. And we see that passion as well in all of our counties, but I think, just proposing or prescribing a model on its own will not be enough. You have to have this willingness to work differently, and that's what we talked about earlier.
Okay, thank you. Thanks very much. Chantal?
Just to go back to Andrew's point around expecting Pittsburgh, because Phil and I did a visit yesterday, and concerns were raised around the potentiality of aspect number being within Pittsburgh. I just wanted to bring that to the table because there was some concern.
Okay, thank you. Thanks very much. Everybody, thank you very much for the report and the clarity of it. I think it's probably one of the most transparent reports that I've seen for performance. Everybody happy to accept the recommendation? So we're going to go on. We've got quite a number of important issues coming on the agenda. So first we'll go to the clinical services plan, and that's Lee. I forgot the operational update. I've ticked it. I'm sorry, Andrew.
It's all right.
It's because, please excuse me, over to the operational
No, it's
update,
okay.
which will flow into the clinical services plan.
It will do. And I think probably the operational update flows from a lot of the conversations we've had
Absolutely,
so far
absolutely.
this morning, if
Yeah.
I may say. So I think I think probably I can be quite brief because a number of the areas contained within it, we've touched on at various points in the either last conversation or earlier on. I think just going back to urgent emergency care, I think one of the things and you've picked up some of the SDEC question, but I think it links into some of the earlier discussion we had as well. You'll remember that through our Transforming Urgent Emergency Care programme, we effectively had three aims, which was to reduce conveyance, reduce conversion, and reduce complexity. When we look at the data now and the metrics that we're tracking to track the delivery of that programme, we are seeing good progress in all three of those domains. As we said, as our plan articulates, we have to go much further next year to be able to start to realise the full benefits in terms of some of the increased costs we've been experiencing because of the surge in demand that we've been managing, but also in terms of improving performance and access. But I think there's enough there now in the data to suggest the approach we're taking and the actions we're taking are starting to gain traction and make a difference. It's just some of the pressure we've seen over the last 3 or 4 months that's mitigated some of the benefit. And then the only other couple of things I wanted to pick up that I don't think we've talked about so far. One, the board will remember there's been an ongoing issue with the outage of Adastra. That finished on the 14th of February, so that came back online. There's still a backlog in terms of some of the information and data that needs to be uploaded onto the system, and the team anticipate it's going to take about 8 weeks to work through that backlog because there's around 8,000 patients' details that we need to make sure is on the system. And then the final thing, which is a positive one, which we weren't quite sure of the outcome when we were writing the report, and it certainly wouldn't have been ready for your chair's report, is pleased to note that through the development of the mental health 111 Press 2 service has won 2 awards in the last month, both with the Dyfed Powys. So the Dyfed Powys Police Awards, but they won 1 award for partnership working and another one for innovation and problem solving. So two good pieces of recognition for that work. Of course, we were the first health board to go 24/7 with that service. So there may be a couple of things that either Alison or Jill want to add, but I'll
I just want to say that's incredible that it came from the police, because that's one of the biggest things that police rate across the UK is the impact of mental health on their services. So it's wonderful. Alison.
Yes, thanks, Chair. It's just to provide an update from the paper around industrial action. So it does call out that there was industrial action due on the 20th of March by WASP members. That was actually stepped down. So as at today, there is no further dates at all for any union to take industrial action, while positive conversations and negotiations go on between Welsh Government and the unions. I think so it's looking very promising at the moment. I think the risk is that if we do see further industrial action, I think we'll see a bigger impact from it, because I would suspect the unions will coalesce and take action on the same day. But at the moment, everything is looking very positive. We've also agreed that we will take the lessons learned report through the People, Organisation, Development and Culture Committee as well.
Thank you. And do you wish to declare an interest in that particular topic? Many thanks. We'll record that. Rodri, Judy.
Yeah, just one question. And I think it's on page 3. From page 2. You know, the table regarding the delayed transfers. What is interesting for myself and useful is putting percentage in the column next door to it. 86 in Glangweely out of how many beds. Do you see where I'm coming from? You can really see then where the issues are, because 86 most probably isn't huge compared to the size of Glangweely in comparison to Bronglais. And I'm not trying to be pedantic in any way, but it would give me a better understanding of which hospitals are causing or have got the greatest problem with the delayed transfers.
Yeah, of course. I'm sure we can add that next time. I mean, it's worth noting that the number of delays is around a third of our overall capacity, bed capacity, about 30%. So and that's fairly consistent across most of the sites. Bronchiolitis tends to be slightly lower in number historically, and sometimes has crept up, but it's generally stayed there. But certainly for the others, it's generally about 30% of the total bed capacity.
Okay,
but we can add that.
It'd be interesting reading, and also you can have a better kind of insight then of. Thanks.
Judith.
Yes, thank you. It's a question on the industrial action. First of all, welcome the update Alison's given. The BMA junior doctors are going on, I think, 4 days. Action is the next in England, and I've seen reports saying the position is being considered in Wales, but I just wonder whether you had any indication. I know it's a different arrangement in Wales in terms of remuneration, but I just wondered whether you were getting any sense that might spread.
We've had nothing through yet from the BMA in respect to Wales.
Good. Okay, thank you.
Dalith and then Jill.
Thank you, Chair. My question's about social worker assessments, and I note in the papers there's Operation Nightingale operating in Pembrokeshire, but looking at the figures in the appendix, we've got significant issues in other areas, other local authority areas. Are there plans for a similar process for Ceredigion and for Carmarthenshire, and possibly Powys and Betsy as well?
Difficult to talk on behalf of Powys and Betsy, but just to take the general point, Operation Nightingale was actually quite a short-term, very welcome intervention by Pembrokeshire Council. What they essentially did was reallocate their social work capacity from community into the hospital in order to get patients moving. And I think the council themselves have acknowledged that that became unsustainable because the workload in the community then demanded those people back. So I referred earlier, and Andrew's picked up on the sort of further faster work. The workshop we're going to have with Pembrokeshire is to think about how we can do this more sustainably, using all of the elements of Home First and seeing where there may be some opportunities there, as well as the overall workforce issues. And Lisa's been in conversation with Pembrokeshire around some overseas recruitment that we may be able to support around social work. The situation, I think, is slightly different in Carmarthenshire, in that there are certainly some shortfalls, and Jill will know this. Home First as an approach is probably the most comprehensive there, and they've got the multidisciplinary team wrapped around that. The challenge in the co-sponsored piece of work between ourselves and the council is about how do we ensure that the community response matches the needs of the people being discharged, because at the moment we've seen many cases where there just isn't the right capacity. So that's the next piece of work. I think we'll get there with Pembrokeshire in time. And as I say, for Ceredigion, partly because the numbers in reality are lower and we've got a capacity issue to kind of ensure we focus on the big challenges first. We're just starting those conversations with Ceredigion, but we will be developing those over the summer.
Okay. Jill, will you want to come on the same point? Because
No, it was okay.
Phil, did you want to come on that point?
Mine was on the point just before.
Okay, well, I'll go to Jill and then Phil.
Thank you. It was really just an update on the COVID booster, spring booster programme. So the details in the paper, but we've got 37 GP practices and 10 community pharmacies delivering the programme. For any practices that aren't covered or haven't signed up, those individuals in the cohorts will be covered by the MVC, so the health board team will pick those up. But actually vaccinations start this week. So all those in the eligible cohorts will receive invitations from their GP practice. So they don't need to worry, that invitation will come. And we will be managing the tight timescale set by Welsh Government, because already Welsh Government are expecting us to identify the last clinics. So making sure that we are delivering this within the timescale set.
Okay, and Alison, you want to add to that point? Then I'll go to Phil.
Yeah, well, it's on this on COVID. It's just to say that as of today, the 4 CMOs have agreed to suspend the level 2 alert system for COVID. So as of today, that's been suspended.
Okay, thank you.
Across the UK.
Thank you, Phil.
Yeah, it was just in relation to the point about any news from the BMA on potential junior doctor strikes in Wales. Whilst that I haven't heard any news on that particular issue, there is a bit of a related issue that there is a BMA rate card that has been proposed that is in the public domain, and there are issues across Wales actually in terms of doctors wanting higher pay out of hours, and certainly in our health board, we are experiencing some of those requests locally. There isn't an all Wales position on that. I mean, Lisa may want to comment, I guess, on that. But, it's just to flag it that it's one of the potential risks going into next year in terms of service sustainability, but also financially.
Okay, thank you, Phil. Any other questions or comments? No, thank you for the operational update. If we now go on to the clinical services plan, please, Lee.
Yep, thank you, Chair. So I think this is an important paper and an important programme of work. So the paper says we have an agreed strategy, and that has been progressed, as we talked about earlier. And the key driver within the development of the strategy was, of course, the fragility of many services that we provide, and that fragility remains. And in some cases, the pandemic has exposed some of that fragility further. So as the paper sets out, we've identified 6 service areas where there is a need for us to review the current service provision, and the drivers for including each of those are slightly different, but broadly fall into 2 categories. Either there are known service fragility issues, for example, critical care and emergency general surgery, which of course is a paper next on the agenda, or there's a need to increase activity to support the reduction in waiting times, which we haven't been able to return to pre-pandemic levels in planned care and diagnostics. The list, I would say, is not necessarily exhaustive in the sense that we have potential for fragility in a number of areas, but of course we do need to be clear on the scope and set some parameters around the work. The other point just to make, and it is picked up in the paper, is that there is a parallel piece of work we're progressing on primary care sustainability. So that work will be developed very much in conjunction with the clinical services plan, and as we mentioned earlier, but starts in a slightly different position in that our strategy is explicit in the future plans for services like critical care and emergency general surgery and so on. But there is more work for us to do, I think, on the strategic direction for primary care, and therefore probably warrants a more extensive piece of work, which will be progressing alongside this. So as I say, the two will be very much developed together, and as we picked up earlier, very much in a multi-professional manner between them both. So I'm happy to just finish there. Andrew may want to make a comment on the critical care position because that's covered in the update as well, but otherwise happy to take questions on the paper.
Thanks, Lee. Okay, you don't have to. Okay, thank you. Any questions or comments? I just think it would send a signal if the primary care strategy was incorporated into the same paper as going forward, if it can be, even just the list of, that one system rather than the separation, because it's a potentially fragile service that is a part of that system. So just a thought. So no comments? Okay, thanks. Happy to accept the recommendation. Sorry, Anna, excuse me.
Sorry, Chair, I know you need to move us on, but I think, the case for this is really clear. We need to do this. We've seen enough examples over the last few months of services being in a position where operational intervention has been needed in an urgent way. So it's important for us to get on the strategic front foot with this. So very much welcome it. But I think we have to recognise that for some people, some of whom may be listening to us today, there will be a suspicion that changes in services are an underhand attempt to centralise services around Carmarthenshire to the detriment of others across our wider footprint. So I'm wondering that as we go through this process, as the process is designed to do this piece of work, how we can maximise the transparency of it, how there might be a role, what we're thinking around citizen voice, how can we be absolutely as transparent as possible, recognising that for some people this will be another sign that we're not serious about our rural footprint and taking those needs seriously.
Thank you, that's really helpful. And as well as the voice of the citizen, it's also the voice of the clinicians who are, at the centre of this. And it connects with our programme business case and the delivery of it, because this is indicative of the journey that we will be on until we get that programme business case, approved and we get it up and running. So yeah, we will, I totally agree. Naturally, people will feel there's a conspiracy when there isn't, And it's important that we are open, transparent and honest and share all the information with the public. So thank you. On that note, the board happy to take assurance from the current actions to address the critical care issues within Prince Philip and approve the establishment of the programme to develop a clinical services plan, which will include the primary care strategy as well. Yeah, is that okay? Okay, thank you. Next item on the agenda is the emergency general surgery, and that's Andrew.
Yes, thanks, Chair. And this is I guess this is an example of one of the reasons that last paper in the clinical services plan and programme is a really important moment for us and piece of work next year, because this is a service that has rapidly tipped, if you like, over the last 3 or 4 months into a position whereby we've had to bring the paper here today. Before I go into the detail, I would like to apologise to my colleagues in the CHC because of the timing of this. We've not been able to take this through a proper service planning and process and service change discussion with them, but I know I've spoken to them in the week, and I've more than happy, as I've said, to bring the team and come and have a conversation with yourselves, LICE, your officers, as a follow-up to the board conversation to answer any questions and explore the detail further. I'm sure you'll have questions today. So I think the key issue here is that the general surgery, the emergency surgery on-call rota, and this is the consultant rota we're talking about in Withybush, it operates on a 1 in 5 basis. We've currently got 1 substantive consultant working full time and an agency consultant who's covering a substantive vacancy. We've got 2 consultants that are on reduced duties due to some long-term sickness, and we've got a locum consultant that's due to retire tomorrow. So where that leaves us is it leaves us with, at the moment, in work 2 consultants to cover a 24/7 consultant emergency rota in Withybush. This has been, the fragility of the service has been on the Directorate's risk register since 2018. It's been refined over the course of the last 2 or 3 years as the specific nature of some of the risks have materialised, but the key issues that have, the key issue that's really brought this into focus now is the fact that the long-term sickness that's happened and the inability to recruit to the substantive vacancy. We have got some locum posts out to advert at the moment that were being shortlisted. We had a good response to that advert, so that will help shore up the position. But there is a challenge in that, in terms of that would still leave a high number of locum posts and agency posts working on a rota which the clinical team feel still carries a risk. So in response to the challenge, in response to that risk, the general surgical teams across Bwrdd, Glangwili and Withybush have been meeting to work through how they best mitigate this position, because with the retirement tomorrow, this starts to become a challenge in April. The model they've come up with is that the teams in Bwrdd and Glangwili will support remotely the middle grade rota in Withybush out of hours. So the middle grade rota in Withybush is strong, and we've not got any immediate concerns or fragility around that rota at the moment. And so the consultants at Bwrdd and Glangwili on a rotational basis will support out of hours the middle grade on call in Withybush. During the day, the daytime emergency cover will continue to be provided on site by the general surgical consultant team that are present and available. There are some key issues here, obviously, in terms of that model. So the intention is, and generally from an emergency surgery perspective, all of the guidance would say you minimise operating out of hours as far as you can, unless the nature of the case and the urgency of the situation necessitates you to undertake an intervention out of hours. So the expectation would be that a lot of the emergencies that would be managed, and we're talking around 2 to 3 admissions per day, would continue to be managed through Withybush, through the daytime emergency lists and by the team on site. What the provision and the model provides for is that in the event that there is a case that requires out of hours emergency inputs, this might be somebody that needs a laparotomy out of hours, they would get transferred from Withybush, having been assessed and diagnosed, and the advice sought from the consultant providing remote advice to middle grade, they would get transferred to Glangwili. We anticipate that that would be only 1 to 2 patients per week. I'm mindful, and I don't know whether it'll carry out the same way, but when we put in place the critical care change, we anticipated a higher level of transfer than we've seen. There's the potential that might be. We're predicting a higher level, so I think we are operating in a more worst case scenario in terms of the impact, but it's still a relatively low impact. In terms of the tie, as I said, this becomes an issue in April. The consultant team in Glangwili have been meeting with their colleagues in Withybush and the physicians in Withybush, and I know the clinical director is really keen to try and maintain the current 24/7 on-call service in Withybush as it is over the course of the next month. The challenge in May is that there's also a retirement from the Glangwili on-call rota that will make that more challenged, and it's probably more likely towards the end of April, early May, that we'd be in a position whereby we might need to necessitate this contingency plan. I have to state that there's been good engagement over the last 2 or 3 weeks between both the physicians in Withybush, the surgical team in Withybush, and the surgical team in Glangwili and Bronglice. There's been dialogue with our primary care colleagues as well in terms of the fact that there won't really be an impact on them in terms of their referral routes into the hospital. They will still refer as normal and direct patients to Withybush as normal. There is a real commitment from the surgical team, the general surgical team, to maintaining and finding a sustainable solution for the emergency rota in Withybush, because we're aware that the 2 key risks, I guess, for us, if this becomes a prolonged period of change, as opposed to just a temporary urgent change that it is at the moment, and we're conscious that within the clinical services plan we'd have to engage on anything beyond that anyway. There is a risk. There is a potential risk to training of the doctors that are in Withybush from a surgical perspective, because although it's small numbers, it may be that there's a issue in terms of the number of cases that they're managing and treating. So we'd have to consider that and discuss that with the deanery. But also there would be there's also obviously a concern from our Withybush physicians around the potential impact on the wider emergency service model in Withybush. Hasten to add, that's not at risk at the moment. There'll be no change to the front door model at Withybush. But that, they're clear that those are risks, and they were very keen that I represented those risks to you today when we discussed this paper. So you were clear that they were things in the background that we were working on. There is a small group of the Withybush Medical Staff Committee that is being set up to provide a view of sustainability, how models of sustainability for Withybush to help work through this and have a forum so that any other challenges that may arise can be identified early, and a small group in an engaged way pull together a response and a contingency plan. So I'll pause there because I'm sure there'll be questions, but I think that gets over the main gist of the paper.
Thank you, Andrew. Questions? Judith?
Yeah, thank you, Andrew. Thank you for the paper and for setting it out so clearly. And I think you're quite right to reference the earlier discussions, and particularly around the future clinical services. 2 points really. You mentioned, and it's in the paper, about the impact on future recruitment and retention, and I guess also traction of potentially new consultants. So I just wonder if you have an idea of timescales for being clear on those. And then I guess my second point, which is linked in terms of maybe the longer term, is whether one of those is consideration of a single surgical rota across the 2 sites. I know that there's distances, and I've been involved in my history with one across 2 other hospitals, which were close together, but actually probably took us long to get between them. So I just wondered if that's part of the discussions.
I mean, I think as part of the clinical services plan, work and program and this particular element of it, we'll have to we'll have to work through, as we have done with other service changes to date, all the available options to make sure the service is sustainable going forwards. As I say, the starting point for the clinical director and for the directorate is that, and for me, is that we maintain the existing model of a consultant on call rota for Withybush, and that it's not necessarily, that it's not a starting principle, that it becomes a combined one straight away. I think the first question is, how do we re-establish that and make sure that's resilient and sustainable? Whether that then takes us into a conversation around, actually, to do that, we'll have to think about how we work differently across the two sites and provide that cover is probably where the conversation will evolve to. But I wouldn't want to sit here and say that that's an option on the table at this point, because we would need to work through that.
Okay, thanks. Andrew, in terms of governance, as this has been progressed, obviously communication is key with the clinicians and with the board and with the public. How do you anticipate reporting as this evolves?
So I would expect, Chair, that like for critical care, we would bring an update back here in we may, won't it, in terms of where we're at, particularly if we've either had to instigate the change or about to instigate the change. It may be that given where we are now, is there'll be a minimal amount of activity or experience to report on. I think within the clinical services plan, that starts to give us an extra level of governance and structure around all of these conversations and how they align, and certainly through the executive steering group that I know Leah is planning to set up to oversee that programme. We would have oversight of all of these changes as they happen, and we will continue to engage, myself, and I know Phil does periodically, and Steve, with the medical staff committee and Withybush to continue to work through this and any other issues that may come up aligned to it, and to try and manage any fears. And I'll have a conversation with Orwena as well, obviously, around how we communicate this and make sure the public are kept up to speed with how those conversations are going. I'm sure that will be part of the overall clinical services plan and work programme anyway, but we can, given the immediate issues around this, we can look at how we do that in a resilient way.
Those engagements with the clinicians and with the public is really, really important. And I'd like to thank the clinicians in Withybush who have spoken, and you know, they've welcomed up your presence and Phil's presence and Steve's presence, and listening and working together and setting up the group for them to take the lead, really, in looking at all the consequences with other colleagues in Howell. So thank you for that. And we will keep. Sorry, did Mance, do you want to?
Okay. There's a couple of things we want to ask, if that's all right.
Yeah, I think that the concerns for us are the communication with the people in Pembrokeshire, because obviously, as Anna just said, there is the risk that people will see that things are being centralised. There's also needs to be clarity on how people are going to be repatriated. So if they're taken to Glangwili in the middle of the night, you know, we've already heard today about concerns about people's dignity when they have to travel without their belongings with them, and an urgent transfer will then obviously mean some transfer back, and some people don't have anybody to bring them anything. So it's the communication is important for us, the time scale of this as well. The longer it goes on, the more concerned people in Pembrokeshire are going to be that their services are dwindling away from them.
Thanks, Donna.
Yeah, no, I note and accept those comments. I think we need to make sure we're strong on the comms around that. And I think a key part of that, there are two key parts of the model being successful and mitigating the kind of impact and experience of being transferred. One is to make sure that we've got capacity to enable that transfer, so that we're not keeping people waiting. You know, I don't want them going back through an emergency department, for example, having been transferred. I'd want them to be going directly to a bed. This would be a referral from an ED to a bed in another hospital. So it's around how we ring fence the capacity of a bed for that purpose. And then secondly, and this would be, and this is important as well, this is a wider issue in terms of how our system works. We need to make sure we've got a robust plan around repatriation in a timely fashion as well. So you know, I would be pushing for that within 48 hours of it being clear that patient can be repatriated, that we are making arrangements to do that within a 48 period of that being determined possible, which is just for that's not a random time frame I've selected. That's consistent with time frames we've got across things like the major trauma network for repatriation of patients from for major trauma from UHW, for example, or Swansea. So we'll those are the kind of standards I'll be looking to enact around that overall model to make it work and mitigate the impact on the patient's experience as far as we can. So recognise those will be concerns and anxieties.
I'm going to bring Steve in. Excuse me, Mansell.
That's all right. No, just a quick one. To aid the transparency from the public perspective, and from what Anna said earlier on, you started your paper by saying that this has been on the risk register since 2018. You then moved on to say that this was now a temporary urgent service change. So could you just explain why this is now an urgent service change when it's been on the risk register since 2018, which would aid transparency?
So I think yeah, that's a good question, man. So I think the challenge with all these things, and if I look, I mean, Mandy alluded to earlier on the number that the work I've been doing in the background around the number of risks. If I look at the risk register, there are a significant number of risks. I think around 300 on our risk register across the organisation that flag service fragility or service sustainability as a risk, and about a third of those are related to workforce challenges and risk, and a number of those are potentially high or extreme risk if they were to materialise. The issue we've got is because our rotas are so small, so in the instance of the 5-person rota in Withybush, it only takes, as we've seen, a vacancy, a retirement, some long-term, one long-term sickness to suddenly mean that those rotas are really fragile and susceptible to not being able to be run in a safe way by the people there. I think we have to note that at the moment, the 1 in 5 rotas being covered effectively by 3 consultants at the moment, which in terms of workload is unsustainable. They've had now and are getting and will continue to get through this next period additional support and input from colleagues in Glangwili on site to do that. But it's really around the small numbers and the fact that because the numbers are small on some of those rotas, it only takes 1 or 2 sudden changes like unplanned long-term sickness that can tip those over. I think what it does pose for me is a question that I'm taking back into the operational teams on the back of some of the review of the risk register I've done, which is how far now with those risks identified can we already start to articulate some of the business continuity plans around the workforce position that we might need to enact if something happened and they similar tipped over. I guess the challenge with that will be until you're in that moment and you're in the face of that and you know exactly what that is, because it could be any one of a number of different variables. You might not be able to completely plan what the contingency is, if that makes sense, because it might be a range of different solutions. But I think there's a question there for us around trying to make sure for those that we've got particularly high risk, that we've got something in the background that's already done some of that thinking, even if it needs finalising and refining if we ever get to that point, which of course we spend all day, every day working to mitigate and manage and avoid getting to that position. That's what for a lot of the operational teams, the workforce challenge means that's what they spend a lot of their days doing.
And if I could add to that, Mansell, that's one of the biggest messages that we are sharing with the public throughout the consultation process is the unattractiveness of our rota system and the fragility of it. And this is the consequence. So we really need to push the programme business case, get the funding from Welsh Government and get a hospital which has, a critical mass of clinicians in that would prevent this happening. Steve?
Sort of slightly slowed my thunder there, Chair.
Sorry.
Just on the earlier point, though, the other question we have is we don't have a team in the health board whose job it is just to do all the contingency planning. It's a sort of obvious point, but there are so many fragile services. It is also partly about how we spend our time trying to plan for as much as we can. But actually, these are operational teams, trying to do the day job, and it's a balance that maybe we haven't got right, but we do need to continue to strike. the points I wanted to make were firstly, what's been really encouraging to see in this, and I think it's based on a whole range of work and the journey this organisation's been on, is the attitude of our clinical teams and our managerial teams to rally around. We saw it with critical care, we're seeing it here, and Phil, Andrew and I were with some senior clinicians in Withybush just last week who are absolutely committed to finding answers to all of this and trying to find a way through. But of course, to make the point that the chair's made, the reason we need to change is because there are very few health board teams, managerial, clinically, at all levels, who are having to deal with the level of fragility that this organisation deals with. And it would be, in some ways, a bit surprising that we weren't talking about a big radical change if we weren't in that reality. But it does, if we wanted to reiterate what we said earlier around the update on the overall strategy, it just underlines the urgency and importance of getting the programme business case through to the next stage so that we can start to build the future. Because I believe there will come a point, and it may not be far away, where it becomes so real to people. We know the land, we've got detailed planning going on, that will start to create a virtuous circle for us of people wanting to come and work, feeling encouraged, knowing about the future. But we've got to get there as fast as we can, because I think that the urgency of this is stark, given what we're seeing.
Yeah, thanks, Steve. So I'm going to turn to the recommendation of the board, subject to the absence of suitable recruitment solutions ahead of the 31st of March. Approve the implementation of the proposed contingency model from April 2023 in order to ensure the safety of patients admitted via an emergency surgical pathway at Withybush and support the continued sustainability of the 24/7 emergency surgical pathway at the hospital. Yeah. And request that an update paper be brought to the 25th of May public board meeting. I'd like to request that that paper include details of the communication, both with our clinicians and with our public, details of repatriation, communication also to include information of accommodation or other support the families can have. I'd also like it to have details of the patient experience and the governance, the detail of the governance that we can continue to scrutinise this and the clinical services plan. Yeah, okay, thank you. Thank you for that. We now go on to the next item on the agenda. It's the managed practice strategy. And again, I'm going to just remind members that we have read the papers. Over to you, Jill.
Yes, thank you. And on that point, Chair, I won't go into the detail. There's a lot of detail here, which is actually about the status of the managed practices that we've got. And I think just reflecting on the challenge of actually bringing this paper to the board, I think it was important that we set out the detail of those 5 practices. And of course, we have a further practice from the 1st of April. And we have indicated a sort of strategic view for each of those practices towards the end of the report. But in a way, you can't actually have a managed practice strategy because you don't know you're going to get one until a vacant practice panel makes a decision that the outcome of the consequence of contract termination is a managed practice. So I do appreciate that this hasn't delivered a strategy in its own right, but we have provided that strategic vision for each of the practices that we've got. I think also it's important that we've recognised that whilst there are challenges in terms of managed practice, and it wouldn't be our long-term plan to acquire more, they will tend to feature, I believe, as part of the range of services that we will continue to see as part of our primary care strategy. And we will be bringing that conversation into the wider strategy that we develop and bring back to the board at the end of the year and in January. But that being said, there have been some benefits to the managed practices that we've had over the years. And some of them we've had, as you can see, one of them since 2015. And certainly through COVID, we were able to test some of the early vaccine rollout. We've certainly been able to try some of the new workforce models through our managed practice. And we also run some services, actually, which we've not been able to deliver through other primary care services, such as our alternative provider, patient provider scheme, through managed practices. So there are most definite benefits. So, as I say, I'm not going to go into the detail here, but there are real challenges for us in terms of estates and workforce in terms of delivering that model. And we're working with our workforce colleagues in the new Primary Care Academy to continue to look at how we deliver the best out of what we've got and share that learning with our other independent practices. But I would be recommending that we will be bringing back that further conversation as part of the wider strategy later in the year. But we have set out in the paper some vision for each of the services that we've got, and I would be wanting to bring those recommendations to the board because they won't be without a challenge, particularly if we think about the first one of perhaps combining Meddygfa, Mynafon and Sarn as a combined practice. That will have to be with engagement. We'll have to take that through a process. We also want to continue to undertake the work in Tenby around the delivery of that walk-in service, along with the practice and thinking about the combined model for the future of the workforce in that area. For Ashgrove, we'd like to develop and continue to develop some of the workforce opportunities that we tested through that. There's also a link there to the Pentra Owl development for Ashgrove, and we've been able to test some of the new models of delivery. We've got a really keen clinical lead there who also would like to be a training practice as a managed practice. We do require 2 general practitioners with a training status to be able to deliver that, because we've also got to have somebody on site all of the time who was a GP trainer. And certainly then in terms of Nayland and Johnston, we have committed to go back out at the end of this year. And we know that the community are looking at ways in which they can develop a different service model for Nayland and Johnston. So we bring a strategic vision for the individual practices that we've got. I've recognised the challenge that you can't have a managed practice strategy per se, because you can't predict that you're necessarily going to get them. But we want to make sure that we are continuing to develop the services that we have through our managed practices, and that they deliver services to the highest quality. But we certainly also have to look at the end point and the link to our wider primary care strategy. So I'm bringing those points to the board today.
Thank you, Jill. Thank you. I'll open it for questions or comments.
Just a couple of things, relatively minor. Some of the rentals on some of the properties seem very high. Now, one of them is 157,000. Thank you. £157,000 per annum just for one. I'm just wondering whether we are looking at alternative premises. And the second point is there's a long list of things to be done in each of the practices, which I'm assuming the health board will have to find from its discretionary capital programme, which is already overstretched. And just wondering how we're going to manage that.
So we do have different rent and lease arrangements for each of those practices, and probably what this paper doesn't define is there's a difference in size in terms of the practice estate, so that may reflect some of the costs. But we work with our specialist services estates team in shared services who undertake the reviews for us to make sure that they are in line with market rent and lease, and those continue to be reviewed. We've got ongoing conversations with shared services around those on a very regular basis. In terms of the issues around the estate and the estate in the condition that we adopted, at the point at which we acquire a managed practice, and this is ongoing with Solver at this point, our estates team and health and safety, fire safety, infection control have to undergo a review of the status of the property, and there will be a plan that is put in place. Now, depending on the nature of the lease, some of those costs will fall to, depending on what it defines in the lease, will fall to the actual owners of the building. And some costs, if it's part of the lease arrangement for the health board, would then have to be picked up by the health board. Just because there is one matter in the public domain at the moment, we have an example of that with Nayland and Johnston. The paper is clear that the Johnston building is closed at the moment for remedial works, and that's because there is ongoing discussion then with the landlords around the nature of those works and the ability to actually progress them. So it can be a dual arrangement depending on the lease, but I would want to assure the board that there is that regular review of the lease, the costs and the appropriateness of those ongoing.
Thank you.
Yes, yes, thank you. And thank you for the paper, Jill, and the detail, which I think is really helpful. I can see how this is part of the overall strategy for primary care, and in that sense, it is an update of where we are. But I suppose some of my questions are around whether there's a view here that there might be a mixed economy going forward. I'm very mindful that one of these practices, as you said, has been managed since 2017. So must raise a question of its attractiveness to go down a different route. And we don't know yet with some of the others where exactly we are. So I suppose what I'm looking for is some assurance that we will look at that mixed economy, if we use that terminology, for the provision of GMS services. And along that line, I just wondered where we are in engaging our workforce of the future. We have about 90, I think, GP trainees with us at the moment who are filling across the patch, who have a commitment to stay with us at least a year after they've finished their training. So where are they in terms of inputting their views to the future model for general medical services? And I guess a separate point really is the appropriateness of this vacant practice panel process. I know we've adopted it, but I'm not sure whether that route is the right one going forward. And so whether that you're thinking is part of that, will that be part of the primary care strategy, or is that something that we can make representations to, well, it's government because it's their process around it not being maybe fit for purpose?
Yes, thank you. So I'll try and pick up all of those points. I think it is important that we continue to test the market, and we have done some years ago. There were some challenges around procurement, but we understand that, and Hugh's been able to update us on this, there are some changes to procurement rules which may enable us to be able to test the market in a different way going forward, and that might make that easier. So we would be wanting to do that, and the 2015 practice will be part of that. But I still feel we need to be having that conversation with the board around the benefits as well as the disadvantages in terms of this. And certainly our work, and with the help of our workforce team and others, you know, the teams that work in those managed practices now have said how much they benefit from being part of the wider team and being part of the health board in terms of that. But I do think we recognise that primary care is fragile. So I do think that we are likely to see a mixed model of delivery in terms of managed practices, of salaried doctors, or possibly APMS contracts, of independent contractor status as well going forward. And that's part of the big conversation we want to have as part of our strategy. We've had a conversation with Lee and team about how we do that. But I've also raised this at a national level because there has to be a change in appetite, I think, in terms of accepting that services will look different. And how do we design those services to ensure we still fulfil our statutory responsibilities about accessible services for our population that meet their needs through GMS? In terms of then thinking about the workforce, again, as part of this conversation we want to have around our local strategy, we want to talk to the VTS courses, and we're going to be inviting all of the trainees to get together with us and our locality leads as part of that, because although they're spending part of their time in general practice and they're communicating with the practice in which they work, we're not listening enough to their views on the model for the future and what they want from their career and service provision. So we're going to be engaging with those trainees as part of that process. And then picking up the issue around the vacant practice panel, there's an element of contractual requirement around this which we wouldn't be able to change. I think the issue that we know will be reflected in new guidance is the process, and we're expecting new guidance in October in terms of that. But we would still be probably contractually bound at the point of a contract termination to go through a process that then looks at those options that we have, which are four, as you know: managed practice, independent contractor status, ongoing APMS, or can't remember what the fourth one is now. But yes, we have those four options as part of that, and they would be contractually bound, so there would still be a process required.
Okay, thank you. Really welcome the engagement with our trainees.
Absolutely.
Right.
And Jill, in the development of the strategy, bringing into bear all those discussions with the GP trainees, etc., can it be built into our board development process so that we can have really in-depth discussions about the risk appetite, etc., of this particular board? Steve?
Yeah, sort of to build on that point, I think Jill's kind of alluded to it, but prompted by you, Chair, we are going to hold some seminars over the summer with the chair, with the board about what this looks like. I think for me, there's an awful lot of parallels, although there's a lot of difference in detail, particularly given independent contractor status and various contractual routes. But we need to use a similar process, I think, to how we approach the TCS programme. So how does it feel to be at the receiving end of primary care at the moment, whether you're in Solva or in Haverfordwest or somewhere else? How does it feel to be a GP or another member of staff? And the sort of the discover bit, that's going to be very important. And I think what's become clear to me in discussions just over the last few weeks is we've got to go back to that point, because if we jump too quickly to the design point, we won't either carry people with us or we may miss some really important things. So I guess what I'm kind of just putting into the board's head, this might be a much bigger ask than maybe you anticipated, because I think we're going to need to go through something similar. And of course, there are 4 independent contractor groups as well. So the intention would be to try and do something similar for all 4 of them. But coming out at the end of that, having a really clear idea about how we're going to run, how we want primary care to be run on behalf of the population and the people who work in it for the longer term.
And if I could just add, and it's going to be a massive piece of work, and I don't think we can underestimate that. And I know we'll have a conversation at a different time around how we support that from a resource point of view. But I think going back to the earlier conversation as well, we don't want it just to be primary care talking to primary care. And I think making the most of the whole system conversations, because this isn't just about designing a model for primary care in isolation. It's actually about primary care within a whole system, and hearing and thinking. And although we do get together and with our clinicians, and we have done for very many years, and we have really excellent conversations when people come together, it's not part and parcel of what we do all of the time. And it's very easy to fall out of that thinking when you are under lots of operational pressure. So having those regular conversations and all of us beginning to think in that whole system way is going to be so important. And so, the benefit of other clinicians and from other parts of the system getting involved in this debate as well will be really important.
Absolutely. It's the pathways for the patients. Let's focus on the patient, and that means everybody across that system being involved. And I think we'll be a trailblazer actually if we take it forward that way, rather than wait for it to be done centrally, because we'll be listening as well and doing that discovery. So thank you. Are the board happy to accept all the recommendations in respect of all the different managed practices that are set out in the paper? Yeah.
Yes.
Thank you, Jill. I don't usually do this, but because we've got such a packed agenda, I'm going to stop now for half an hour's lunch. I am sensitive, Maddie.
It's not the lunch, it's the needing to move.
Need to move. So if we break now and come back at just after 15:15, okay? Thank you. Lunch is served.
Charge this up.
Welcome everybody. We are going to start the meeting again. So if I can pick up the item on care home capacity and fragility report, and I'll reiterate that we have read the paper. So over to you, Jill.
Yes, thank you. And we've also had the opportunity of discussing some of this detail at a recent board seminar. But I think it was important for the board in public to see the issues within our care homes, to understand the status and the challenges, but also the opportunities, because the independent sector forms a really important part of our whole system. And we note, particularly in recent months, the level of fragility that we've seen. We understand the experience through COVID, and I failed to include actually the care home that we also lost in February of another 31 beds. So for us, this is a significant challenge, and it's a challenge for the whole of the region. And where we are really from a strategic point of view is that our market stability report, which looks at stability and sufficiency, has clearly highlighted the issues around fragility and the sufficiency issues in terms of the particular challenge around nursing beds with an EMI focus as well. So I think that's a challenge for us. The Institute of Public Care have been working with the region to undertake a piece of work, and there have been quite a lot of workshops to scope out the priorities and some of the opportunities that we may have going forward. So we're expecting that report to come out after the commissioning group tomorrow, which will raise some of the options that you can see broadly set out here for the region. But they will require resources. They'll also require providers to be interested who've got possible capital available to be coming into the area, but they'll also be needing us to think very differently around probably our traditional way of working in terms of how we see care homes at the moment. And you know, we are working with Carmarthenshire Local Authority around development in Pentre Owl, for example, where there is an expectation around a care facility which the local authority would be funding the building. We would be working with the local authority then in terms of looking at the workforce. So there are options there, but I have also raised this at a national level with Welsh Government and the Chief of Social Services at Welsh Government and the lead Chief Exec, saying, you know, we really need an all Wales discussion really around the future of the care home sector, because when it's not there, you know, we need that capacity, and we're seeing across Wales, I think, a level of fragility that we haven't seen previously. So I wanted to bring the issues to the board today. We recognise the fragility, but also the scoping work that we're doing. But there isn't going to be an easy, quick solution. And I think it is important that we continue to work where there are care homes that are in escalation or have challenges, and we normally do that. The report does clarify that the last 3 care homes that we did lose were not those where interventions from either health or social care could have prevented the outcome. But we do work very well with our local authority partners in supporting care homes within the region, not only with training and support, but also where there are challenges, working with them to get them back to a level of delivery. So the report's here today for board members' information and understanding, really. Thank you.
Thanks, Jill. And as you say, it's really important that this information is in the public domain for the public and other services such as GPs, etc. Any questions at all?
It's more one about future planning. The information here is great, really, really useful. So thank you for that, Jill. But in some of the tables at the end of the paper, we're projecting up to 2030 in terms of population and in terms of dementia cases. Wonder if we've done any modelling about what would be the impact of those changes on our need for care homes and EMI beds in particular.
I don't think we've done the level of modelling in that detail, and it's something that I think we need to be picking up both within our strategy, actually, because this is the population that we're going to see, and we're going to see an increasing number of individuals with complex needs who require care in the community. And that may be care that can be met in their own home with the sorts of opportunities we talked about earlier today around Home First and others, and growing that home workforce model. But there'll be certainly others who have a level of complexity that will require residential nursing care. So I do think we need to be doing that modelling. And then it comes out of the sort of plan that we're expecting to see from IPC around some of the more innovative solutions that we haven't got in train at the moment, but they do require a level of resource that's almost outwith the health board. And that's why, as I said, I've been signalling the need for a far bigger conversation really around how we attract providers into the area in the future. But as you say, Maynard, we almost need to know what the issue is that we're trying to address here and the type of facility or resource or support that we're going to need.
Okay, thanks, John.
Thank you. Any other questions? Can I just pick up a couple of points? I totally agree, and I'd like the board to ask for that at the right time, for that sort of demand capacity modelling for the future to be done either by ourselves or with partners. But also, it also brings to fore when you've got the last bullet point about the market stability report, including that of the care sector. The priorities will be presented to IEG and thereafter the RPB, and it is broader than those two. So, as we said with the other papers about the governance in respect of the three statutory authorities, the RPB, the IEG, etc., where we can track delivery and resources. And I just wondered if that piece of governance work could come back to us in July, so we've got a time frame on it as well. I think, and we've just had a quick discussion, the governance work on the delivery of our annual plan is number one, but following that, then we look at this, which is much more complex. And we can have the opportunity to discuss it as well, because I do understand the complexity. And we're very fortunate that we've got the chair of RPB on our board, so that's super. Okay, so on the basis of that, the board happy to accept the recommendations plus those two additions. Yeah, thank you, Jill. Thank you for that, because I think it's the first time we've seen the analysis of the now and the possibilities of the future. I did share this paper and the previous paper with the LMC following our meeting with them, so that the GPs can also have sight of it. Steve?
There was just one, it's not really connected to the paper in itself, and I wanted to make sure the chair finished first, but just for the board to have in mind, bring to attention table 7 here, because we're going to be talking about our digital strategy in May. Therein lies a huge challenge for us, not just in the care home market, but actually across all of our services, both in health and social care, given the forecast number of working age people versus the number of old people, even in the next 10 years. It's just a signal that we've got a big problem coming, even if now it feels like things are very challenging.
Yeah, thank you. Okay, if we go on to item number 5.1, which is the programme business case and the fire precaution works. Andrew?
Yeah, thank you, Chair. I'm hoping I can be fairly brief on this in terms, I think the paper's fairly self-explanatory. It presents the programme business case for the next phase of our fire safety programme, which we've been working very closely with the Mid and West Wales Fire and Rescue Service and Welsh Government on over the last couple of years. There were 3 phases of work identified with the last round of visits. A significant amount of the first 2 phases have been undertaken within our discretionary budgets, and this programme business case is for the final stage of that work, or final phase of that work, which requires some more major capital funding. So,
thanks, Andrew. The board happy to approve the business case? Yeah, thank you. Next item on the agenda is the electronic patient flow and observations outline business case, and that's Hugh.
Dr. David. This is, as you alluded to, the flow system and EOB system. Quite a significant investment requirement here, recognising that there is a degree of capital investment needed, as well as some very significant non-recurrent investment needed in order to make the systems work. What this does, it would be a flow system that would automate and operationalize many of the decisions that are currently paper-based, and secure benefits in terms of flow across our system. There are a number of providers out there currently, but generally they are limited to acute organisations only. So we are pushing the market somewhat by trying to stretch both ends of that to see what the scope of the opportunity would be before admission and post-discharge to support patients and communications more broadly. So an interesting opportunity for us to get in this space probably at about the same time that ICSs in England are now starting to think about the opportunity of thinking across their communities in terms of services that they provide. There are two disparate systems here that we would be seeking to roll out at the same time. So the flow system and the EOBS system. So EOBS would secure electronic observations potentially wherever you may be under our care, whether that's in community or whether that's in our acute setting. We've already got much of the technology that would need to wire into this. So our vital signs monitors across the health board are already Wi-Fi enabled, already have the wireless connectivity that we'd need to connect into this. So this would really make sure that we can maximize the value from that investment that has previously been made. Somewhat challenging to work through what the financial benefits would be of this. We can be quite clear on the cost of implementation, but the financial benefits require us to think very carefully about the change management opportunities that come through from this. It requires us to work very differently as an organisation. What I'm seeking today is approval from the board to go out to test the market, to understand what the opportunities might be in the market, and then we'll bring back a more in-depth report or assessment of the financial benefits before awarding any potential contract. There's nothing in our annual plan at this stage to recognise this investment, and you'll note in terms of timetable that we'll be looking for this to kick in potentially in the autumn. So we won't do anything without being very clear on the benefits and where the benefits would come from, and it will itself require a further board approval.
Okay. Thanks, Hugh. Any comments? Stella?
Diolch, Chair. I've just got one comment, really, and a question to ask about stakeholders and how much involvement of staff have you made, especially in the EOBS bit. Being a nurse myself, nothing can replace eyes, ears, and, well, eyes and ears then of a nurse or a clinician. So how much work has there been involved in the scoping out of this model as to what you can't replace that clinician? So really just a little bit of information about what involvement you've had from staff groups and stakeholders in the thinking of this model. I'm for anything that will improve our flows, but I don't want us to lose that human touch too.
Absolutely. You can't replace eyes and ears, and this certainly won't replace eyes and ears in any sense, but it will provide us with that kind of oversight of what's happening across our system. So we will understand not just how many people are in our beds at any point in time, or indeed potentially in our beds and being monitored and supported at home, but we'll be able to understand what the risk is across the system as well. So that gives us a degree of intelligence that we don't have now. It'll allow us to be more proactive in our care. In terms of the engagement, fairly early stages in that would be fair to say. It probably goes back to the comment that Steve made earlier on around the annual plan more broadly, and the digital element does need more engagement. And we're working through how best we get that engagement with people who will ultimately need to use the technology most efficiently. So yeah, absolutely, we'll pick that up.
Yeah, if I can just come in on that, I think it's absolutely fundamental that we get a system in place that drives and supports patient flow from the patient's home all the way through the system and back again. I think the element that we, as Hugh has clearly indicated, needs considerably more thought put through is you can buy any system, it's how you implement it in practice. And whilst remote monitoring of e-observations in particular in the community can be managed perhaps through somewhere like Delta or through another mechanism yet to be clarified, the element for the acute service is going to be really important because we haven't got staff sitting looking at monitors. So that engagement through the what has been known as the R-Rails group and they're changing their name at the moment. And we've just got a new clinical lead, Dr. Helen Monroe and David Wastell, will be absolutely critical in terms of understanding how we can make this work in practice. So I think it's a really important question for us, Delith, to really think about. And I know that my brief conversation with Anthony has suggested that there needs to be some further work on this from a clinical perspective in terms of engagement to make it work in practice.
Yeah, and we can learn the lessons from Wickes, can't we? And other systems.
Absolutely. And, I come back to the point I made earlier on, people, process, technology, the people have to come first in this. One area that I think we will be testing the technology to its limits is, as I say, a flow system normally has a hand in and a hand out. This could well end up being recognition that we are now in a place of probably providing a continuum of care. Where there may not be a natural handover, where there may not be a natural end point. So it may end up being home through to hospital, back to home or back to another setting. So it potentially will allow us to integrate our services far more than we've currently got. But as I say, we need time to go to market and make sure that providers could meet that challenge for us. So we will be at that point able to go out for much more engagement to understand the full potential benefit.
Thank you, Paul.
Yeah, something that's been a recurring theme in listening and learning subcommittee meetings and in ombudsman's reports and in complaints is issues arising out of what would be characterised as poor handover communication. Yes. And that whether that's between shifts or between clinical areas. Will the system help to address that and make it a more smooth transfer of care when it goes from one section to another or one shift to another?
Yeah, there are a couple of things that it will inevitably incorporate. Conscious of the point that you made earlier, Mandy, about that mental checklist that you almost need. Well, this will require checklists to a certain extent because we will need to order tests or order therapies input or whatever at a certain point in time in the patient's journey. So it will automate some of that requesting of further support as part of a patient's journey, and it will inevitably incorporate a degree of communication between practitioners. It won't fully address the issue because I think the issue is also cultural as well as systemic, but it will be a repository which can support that better communication.
Okay, thank you. And one of the issues raised by the district nurses was they love the Welsh nursing care record, but they can't get, it's only the acute and we need to get that joined up. Okay, on the basis of that discussion and on the basis that this is a work in progress and that the views of the clinicians are absolutely essential as to workability and culture, is the board happy to accept the recommendations as they stand? Yeah, thank you. Next item on the agenda is the New Velindre Cancer Centre full business case approval. Lee.
Yeah, thank you, Chair. So the S-bar that's provided is the same one that's being used across all commissioning health boards. So it is very detailed. So I'll just pull out the key points just to help board members on that. So people will be aware of the plans for New Velindre Cancer Centre Hospital, and the board has previously approved the outline business case. So the main change, I guess, in relation to that for us to be aware of as a board is that there's been a further increase in costs to us as a health board of 16,000 between the outline business case and the full business case. So obviously, as the majority of our patients access care in Swansea, there is a relatively marginal impact for us as a health board. The figures that are the other figures that are presented there for clarity. So the full business case requires a contribution of 139,000 from ourselves. That is against the 123 that was previously in the business case, which is the 16,000 difference. And we've already have 62,000 of that within our baseline contract. Hence why there's an uplift of 77,000 between what we've already put in and what we would need to put into as part of the full business case. So I hope that clarifies quite a lot of tables into a fairly simple summary. So on that basis, as it is a movement of 16,000 in between the outline business case we'd already approved to a full business case, our recommendation is that the board approves the FBC.
Thanks, Lee. Is the board happy to approve the FBC? Yeah, thank you very much.
Chair, could we just
Sorry.
add that in making that decision, the board have been shared the full set of papers, some of which are commercially sensitive, which are in our committee. So that has been considered in making this decision, Chair.
Yeah, thank you, Chair. Next item on the agenda is the Sustainable Resources Committee. I think, Maynard, you're going to step in as Vice Chair. And again, we have read the papers, but if there's anything specific, please draw it to our attention.
Nothing in particular to add. The main thing I'd like to draw attention to was the limited assurance on the process of implementing the strategic programs of change. I think we've already echoed those in discussion of the plan earlier, but particularly wanted those. Everything else has been covered in discussion today.
Thank you. And on that basis, I assume the governance work that's being done on the processes will be reported to SRC. Yeah. Okay.
Chair, I should mention earlier, there was actually an internal audit report as well on this, which will help us with some of the governance. So we'll use that as the baseline to design the new governance going forward.
Thank you. Okay, thank you, Maynard. And we go on to the SDoc.
Yeah, that's me again. Just one thing to add to the paper. You note that the Bronx strategy implementation was reported as being behind, but one of the sort of positives that came out of that was that the strategy is being reviewed as it's being implemented to make sure that it's still right and relevant. But progress is now being made on that. There are a number of things that came to committee that need board ratification. They were attached as appendices or annexes to the report. The first one is the integrated executive group advocacy strategy. Personally, I think that this one is a brilliant piece of work and extremely relevant. We've already dealt with the Bronx Hospital fire improvements.
You may have to put the microphone a little bit. Thank you.
Terribly sorry. Yeah, there's a number of allocations over £500,000 in the discretionary capital programme. I keep wanting to say just DCP, but things. The capital programme for 23-24 is there, needs improvement. Improving together framework was considered at SDOD. And we also looked at the public service board wellbeing plans, which are a separate agenda item. So those are the only things that I think we need to draw out. And
thanks ever so much, Maynard. Is the board happy to approve those issues? Yeah. Okay. Thank you very much. I'm going to go on now to the People Committee, and Judith is kindly going to speak as Vice Chair.
Yes, thank you. The report's there for everyone to see for any questions, and I know the chair of the committee, Chantal, would like me to again say how pleased we are with the quality of the papers that always come to this committee. Just a couple of things to highlight. Members will see on page 3 a very large range of policies that have been through the committee and approved, and also good to see that we recorded 4 appointments into consultant posts at the last meeting. There was nothing to raise at the board, so I'm happy to take any questions.
Thanks, Judith. Any questions? Thank you. The board's happy to receive that report. And still with you, Judith, is the report of the Health and Safety Committee.
Yes, thank you. Again, nothing particular to raise with the board. I again draw attention to some of the policies that were approved at the committee. And in terms of matters of concern, they're listed on page 3 and 4. And you'll see that with those, they are all being followed through. And just to add, we were given a verbal update on the Bwrdd fire precautions, so that will be reported through this committee as we do with the other reports. But that's all. I'll be happy to take questions.
Thank you, Judith. Any questions? No, board's happy to receive it. Thank you. And if we go into the committee update reports, sorry. Yes, please, Judith.
So, thank you, Chair. So this report covers remuneration in terms of service, charitable funds, Mental Health Legislation Assurance Committee, the Lasting Committee Board and the Stakeholder Reference Group. There are 2 items which do need the board approval, but we'll take those in the corporate trustee session, but we need to just flag those here as well. And there is also a matter from the SRG in relation to ensuring we involve colleagues on the SRG earlier in consultations rather than at the end of the process. So I think that's a really valid point to raise. And there's also a matter from charitable funds in terms of rationalising the number of funds which we've been asked to raise to the board's attention, Chair.
Okay, and we will consider that one as well in the trustee. Okay, any comments, questions? No. Okay, thank you. They've all been received. And then the working in partnership, 7.1.
Nothing from me, Chair. Any questions? Be happy to take.
Any questions? No, thank you. Statutory partnerships, Jill.
Yes, thank you. Just want to draw board members' attention to an item that does need to be approved today, please, and that's the work that's been done by each of our PSBs. There was in 2022 the wellbeing assessments. These have now developed into the local wellbeing plans, which run from 2023 to 2028. A huge amount of work has been done. The links are appended here for board consideration, but we do need to approve these today, please.
Thanks, Jill. Is the board happy to approve the wellbeing plans? Jo, did you want to say anything?
No, I think just mainly covered it. That it was just to say, although each of our PSBs has produced a separate plan, there are 4 key elements that are going through each that they're all focusing on and have produced. Have got subgroups together in terms of turning the kind of aspirations into action. Their economy and employment, reducing health inequalities and tackling poverty, the climate and environmental well-being, and diverse communities and cultural well-being. So all of our PSBs have produced very mature reports in line with Wellbeing of Future Generations.
Thank you. And it's great intelligence for us to work and take into account. Thank you very much. Board's happy to approve those plans and to receive them. So the next item on the agenda, I think, is the board annual work plan.
Yeah, and we'll need to update that, Chair, based on today's discussions.
Okay, thank you. And then the date and time of the next meeting is Thursday, the 25th of May at 9:30. Whether we're in this room or not with the magic windows and park chairs, I'm not too sure, but I'm sure we will take your feedback very seriously. And then we will, I think we should go into trustee in the open.
Because we can still live stream for the trustee.
That's great. Thank you. So any apologies?
Chair, we have a few apologies now. We'll have Winston Weir, Yuan Thomas, Chantal, Patel, Mansell and
Okay, many thanks. Any declarations of interest? No. Thank you. And so the next item on the agenda is the corporate trustee session, and I assume that's you, Mandy.
It is, although I'm going to have to do this sharing
Bless you.
Delith's reports. So let me just get to the first one that I need to pick up on. Yep, that one. So with this particular report, bear with me a second, sorry, this is the annual report and annual accounts that have been provided. I almost feel as though we've seen this several times. And certainly I'm sure Delith feels that she's seen her photograph several times in this particular report. I think what it does demonstrate is the significant breadth of activities that have been undertaken to raise funds to the benefit of our population who we can improve experience through, and also the well-being of our staff as well. So I don't want to say anything more than that. I think it's probably just to receive and if there are any comments.
Thank you. And any comments?
Yeah, just an observation. I think, the position, I think, is somewhat distorted this year by the position with regard to the chemotherapy day unit in Bwrdd, where we raised the money but haven't spent it. But more generally, are we churning the money through the system as quickly as perhaps we should do or could do? Because, as you say, we're raising the money in order to improve patient care, improve staff position, not to play the stock market or have large sums of money invested. So are we churning the money over quick enough?
I think that's a really important question, and it's one that is a little source of frustration for me. You're quite right. The income that's been generated, or the donations that have been raised as a consequence of the Bwrdd chemo appeal in particular, if we park those to one side, what we've actually seen is a bit of a bucking of what we expected to happen in terms of the trend of income for our charity. So the team have worked exceptionally hard, and we've actually seen an increase at a time when economically we would have expected to have seen a decrease in donations, grants and legacies. So we're really positive about that. There has been a decrease in expenditure, and it is something I'm going to be picking up with the head of health charities, because I'm really concerned about that. We work very hard from a charitable funds committee perspective, and also the subcommittee works really hard to make sure that we consider all and every application that comes forward. We've tried to make it easier for staff to actually apply for or make an application for the funds. And I think the point that was raised in board around the number of funds that we have is actually hampering the way in which we can utilise the resources that we have. I do know that there is some nervousness about streamlining the 270 plus lines of funds that we have, but that does make it very difficult. If part of the organisation only has £50 in their pot, but they need something that's going to cost £1,000, then we can't spend the £50 without a number of people coming together to sign that off. So I've actually asked the board secretary if I can have some independent advice about the way in which we go forward to actually undertake the streamline, because there are some anxieties based upon historic management of those funds, and I think the sooner we can move towards streamlining, the better we'll be able to spend the money for which it's intended. Long-winded, but I apologise.
No, I understand. One of the first things I did when I came in as chair was ask for a breakdown of all the lines, and I couldn't believe it, because I've come from another charity where it was open to use across the organisation, but the restricted funds I think is quite it is, yeah. Any other questions? Delith, as chair of the Charitable Funds Committee.
Sorry,
please.
just for clarification as well. As Mandy alludes, it is quite emotive. People give money to certain things, shall we say, or certain departments. So this has got to be managed very, very well. We are looking at guidance from the Charities Commission as well. And we have got certain committee members who have got experience of having done some ratification with other charitable funds in the past. So I think all in all, I think, Paul, maybe in a year's time, you might see that we will be spending much more money. I think people do want to see us spending money for our patients and our staff. And as chair, that is the constant dig at our charity, that I have to make sure that we do spend the money appropriately.
Absolutely.
For the benefit of our patients and the population. So thank you, Paul, for that challenge.
Good.
It will be completed, I assure you. Thank you.
Can I just say that the annual report is heartwarming, and to thank the team and yourselves. It's really uplifting to see the community kindness and, raising funds in so many different ways, and staff raising funds, and the lovely pictures. It is really, really heartwarming. So thank you for that.
Thank you.
So is the board happy to ratify the final charities annual report and accounts 21-22? And a massive thank you to you and the team. Okay, the next item on the agenda is the item 2.2, the ratification of charitable funds approvals over 100,000.
Yeah, so the report, I won't go through it, but basically the approved governance support costs and budget for 22-23 was 508,259. For 23-24, it's requested that there is a budget of 524,755, and that reflects the inflation, but also the level of activity that the team have been undertaking. So, and recognise that they're going to need to undertake going forward. So it was really, that's the only point of approval from corporate trustee.
So the board's happy to ratify that? Yes. Yeah. Oh, sorry, I should say the trustee is happy to ratify that, excuse me. And then the next item on the agenda, I think it is the integrated performance report.
No, I think that was just an attachment.
That was just an attachment.
Yeah.
So it's any other business? I think Hugh.
Me, thank you. I just wanted to note that the JC Williams Memorial Trust has been closed, wound up, and the funding has been transferred from, I believe it was a Pittsburgh National Bank, to us, and the final value of that was 1.2 million, 1,216,000 pounds. The valuation on the investment value had dipped over the last 12 months, but that dip had been offset because sterling had weakened against the dollar. So that the loss there was made up for by the gain because of that weakening pound, and that came in before the recent jump up in the value of the pound. So that's good news, and that adds to the Llanelli hydrotherapy appeal fund that we already had of 303,000, so we've now got 1.5 million. So again, coming back to your point, I guess, Paul, we will have an inflated value within the accounts towards the end of this year, given the timing, but we know where this will be spent. So worth noting our thanks as a board to the trustees of the JC Williams Memorial Trust. It's a phenomenal gift from the other side of the Atlantic to support our patients and our community.
Absolutely. Can we write a formal letter of thanks and also give them, when the hydrotherapy pool is in place, send them, a photograph to show them how the money has been spent for the benefit of the people in the area.
Thank you.
Thank you. Any other business? Okay, that's the end of the trustee meeting, and the time and the date of the next meeting will be confirmed. If we're going to come off television now, and we're going to go into in-committee board. 2 minutes, yeah.